Anyone from Mamta team?
Yes, ma'am.
You will have to play the videos, 3 videos after my lecture. Do you have the videos?
Yes, yes, yes.
Should we start, ma'am? Morning, ma'am. Morning, everyone. On the third day of COVID training, today on this session, we will be discussing basically on invasive ventilation. And the first three session will be done pre-lunch, and the next three session will be done after the lunch. In the first 2 days, we already have learned about the COVID um, pathophysiology, management, oxygen therapy. And today we will basically focus on the invasive ventilation. The first topic will be covered by me. I'm Dr. Manisha from Associate Professor from MLN Medical College, Prayagraj. So I think most of the people are still joining, but we have to stick to the time so that everyone takes the full use of the time which they are logging in. So we'll be starting with the first session. The first session is basic terminology of invasive ventilation. Now the specific learning objectives are concept of basic parameters of mechanical ventilation, the parameters that control oxygenation, the parameters that control ventilation, and video demonstration of how to set up a ventilator. Now, one by one, we will be discussing the various parameters which we set on a ventilator. The first is respiratory rate, or we can say frequency. Respiratory rate is the number of breaths the ventilator will deliver per minute. And the initial rate which is set is according to the physiological rate for that age. And we all know that in the first day, we studied what is tachypnea and what is the physiological respiratory rate of children. And you know that the children usually have a higher rate than adults. So, for example, if we see a new name, that is a child, a baby less than 1 month, he will have respiratory rate of about 40 to 50. Normal respiratory rate 35 to 40. So we can set around 35 to 40. And if we see an infant, that is a baby who is less than 1 year, the respiratory rate can be about 30 25 to 30. So we can set a rate around that, about 25 to 30. And for children less than 5 years, the respiratory rate maybe we can set around 25, and above children we can set about 20. And in older children like adolescents and adults, we usually set around 12 to 14. So the initial rate is set according to the physiological rate, and since the children have higher physiological rate, the respiratory rate set is at the higher side than adults. And since the respiratory rate determines minute ventilation, that is the product of tidal volume and respiratory rate, it thus determines the carbon dioxide elimination. So the titration of respiratory rate, that is how to manipulate respiratory rate, it can be done according to the PaCO2 level, which we learned yesterday. That is in ABG, we get partial pressure of carbon dioxide. And our intention is to set normal PaCO2 level. If the PaCO2 level is towards the higher side, that is, it has exceeded the more than 55, or it is causing respiratory acidosis, then we have to manipulate respiratory rate to cause carbon dioxide washout and to have a eucapnic ventilation, that is normal PaCO2 level. So the titration is done according to the PaCO2 level. Now the second one is tidal volume. Tidal volume is the volume of air that is delivered to the patient during a ventilator breath. So in a volume control mode, as we have seen in most of the adult modes of volume control mode we have used, it is preset value. We set a tidal volume, but in pressure modes, as it's used in most of the children in pediatric age group, we usually use pressure mode. We don't set a tidal volume. The tidal volume is variable according to the lung compliance and the airway pressure. So whenever we are setting a pressure control mode, we are putting the patient on pressure control mode. It is also important to see whether the tidal volume is in the desired range. The desired range of tidal volume is around 6 to 8 ml per kg. So if we are setting in a volume control mode, we have to keep our range around 6 to 8 ml per kg. If we are setting, if we have put the patient on a pressure control mode, we have to see on the derived value on the ventilator panel whether the tidal volume which the patient is receiving adequate or not. In ARDS, we usually keep tidal volume in a lower range. That is, we start with a 6 ml per kg, as higher tidal volume may cause further lung injury. And tidal volume is also the determinant of minute ventilations, as minute ventilation is the product of tidal volume and respiratory rate. Next, the most common terminology is FiO2. FiO2 is the fraction of oxygen in the air-gas mixture. Normally, we don't give a pure 100% oxygen, as 100% oxygen may be causing oxygen-related toxicity to the lung. So, we give a air-oxygen mixture, and what we keep the FiO2 is in the range of 21% to 100%. That is 0.2 to 0.1% from atmospheric air to 100%. So we have to have a percentage of oxygen which is delivered to the patient. And FiO2 usually improves the oxygenation status. So the titration of FiO2 is done according to the PaO2 level and the SpO2 level, so that we have to keep both this in the acceptable range. As we have studied earlier in the last 2 days, that PaO2 level, the normal PaO2 level is around 80 to 100 in pediatric, and in newborn age maybe around 60. So the acceptable range should be according to the age, and should not be very vigorous. So the acceptable can be around 55 to 60 PaO2 level, and the SpO2 acceptable is around 90 to 94. So whenever we are seeing that the child is having hypoxia, we can increase the oxygenation by increasing the FiO2. But while setting the FiO2, we all have to keep in mind that FiO2 beyond 60% may not be good for the patient. So once the patient has settled with other parameters, like we have increased the pressures and we have increased the PEEP, we have to try to decrease the FiO2 to less than 60% as soon as possible, so as to avoid oxygen related toxicity. Now the next is PEEP, that is positive end expiratory pressure. So positive end expiratory pressure is the pressure that is maintained at the end of expiration. The main functions of PEEP are to improve the ventilation perfusion matching and oxygenation by decreasing the intrapulmonary shunt. So what is intrapulmonary shunt? Intrapulmonary shunt is the amount of blood which is coming from the heart to the lungs for oxygenation is going unoxygenated again to the lung. So some percentage of, because of the lung damage, some percent of blood which is coming from the heart for oxygenation doesn't get oxygenated and again returns to the heart. So if the shunting is more than 15% or 20%, the patient may be facing a severe hypoxic condition. So PEEP improves PEEP just decreases the intrapulmonary shunting by increasing the ventilation, by improving the ventilation perfusion matching, and thus increases the oxygenation. And the second function of PEEP is to increase functional residual capacity. Functional residual capacity, or FRC, is the amount of air that is left in the lung after normal exhalation. So there has to be some air in the lungs after exhalation so that alveoli may not collapse, and in each respiration more efforts are not required for opening up the alveoli. So what does PEEP does? PEEP increases the FRC, it recruits the collapsed alveoli in a diseased lung and thus improves the lung compliance. So in this diagram, we can see the ventilation perfusion mismatching and matching example. So first, let us see this alveoli. This is partially collapsed, that is low PEEP has been delivered to this alveoli. So ventilation in this area is poor, but perfusion is good. So this is ventilation perfusion mismatching. So perfusion is good, but ventilation is poor. Let us see this alveoli. In this alveoli, we can see that it is over distended. So over distended alveoli will go and collapse this circulation, and it can decrease the perfusion. So in this also we have a ventilation perfusion mismatching. Let us say this alveoli. In this alveoli we have given adequate PEEP. so that we can see that both ventilation and perfusion are adequate. So PEEP provides a proper, it maintains a ventilation perfusion matching by recruiting the alveoli. But while setting a PEEP, we should also keep in mind that PEEP may cause overdistension of the lung, and overdistended lung will decrease the venous return to the heart, and decreased venous return to the heart will cause decrease in cardiac output. So, and decreased cardiac output will cause hemodynamic instability. So, while setting the PEEP, we should always monitor the blood pressure of the patient. And PEEP and high PEEP may also cause air leaks like pneumothorax and pneumomediastinum. So, all these things has to be kept in mind while setting a PEEP. The initial setting of PEEP is around 3 to 5 centimeter of water in children, but in ARDS we can start from 8 centimeters of water. PIP, that is peak inspiratory pressure, that is the highest pressure reached during inspiratory phase. PIP also increases the oxygenation, but inappropriately high PIP, as does PEEP does, it also causes air leaks and barotrauma. So high PIP should be avoided. And sometimes in a volume control mode where the PIP is not set and it is variable, if we find there is an increase in PIP, that indicates that there is some airway resistance like secretions, bronchospasm or mucus plug. So whenever in a volume control mode, we always, like in a pressure control mode, we have to look after the tidal volume which is being delivered to the patient. In a volume control mode, if we are setting, we have to monitor the PIP which is being delivered to the patient. And if we find that there is sudden increase in PIP, that it may indicate that there is some airway resistance which has caused increase in PIP. And this resistance can be because of secretions, which can be improved by suction. Bronchospasm can be improved by nebulizing the child, and mucus plugs can also be removed by nebulizing with N-acetylcysteine and then suction. So these things should be always seen whenever we are whenever we, in a volume control mode, PIP always has to be monitored. And in a pressure control mode, in which we set a PIP, initial setting is 18 to 20 centimeters of water. So let us see in this pressure time graph, we can see that there is a baseline pressure. This is PEEP, that is positive end expiratory pressure, that is pressure maintained throughout the cycle to recruit the alveoli, to prevent the alveoli from collapsing. And the PIP is the pressure, the maximum pressure which is delivered by the ventilator in each breath. So this is PIP and this is PEEP. And one should always remember to pronounce both these terminologies properly when giving the order to the junior residents or the nurses, so that these things can be set properly. Now next one is the plateau pressure. Plateau pressure is the alveolar distending pressure or pressure applied by the ventilators to the small airway and the alveoli. So for example, if we see that the ventilator has provided a peak pressure, has given a peak pressure to the patient, but while going through the various alveoli, there is some resistance is achieved, some resistance is encountered by this pressure, and the pressure which reaches up to the small airway is decreased, and that alveolar distending pressure is called the plateau pressure. And plateau pressure usually reflects the lung compliance. More is the good compliance, more plateau pressure, more alveolar distending pressure, more pressure will reach up to the distal alveoli. And while this plateau pressure is usually not set on a ventilator, it is monitored by the ventilator display unit, and it should be kept around 30 centimeters, around or less than, it should be less than 30 centimeters of water. Usually this is plateau pressure is not set. We derive it by doing a inspiratory hold maneuvers. That is, we hold the inspiration for around 0.5 seconds, and then ventilator will display the P plateau. Sometimes in ventilator display unit, we can find P plateau as such without the inspiratory hold maneuver. They are false P plateau. So if we want to derive a proper P plateau, a correct P plateau, we should have to do an inspiratory hold maneuver. The inspiratory hold maneuvers are done. There are sometimes in ventilator display unit, there may be direct button for inspiratory hold maneuvers, or you can find this inspiratory hold buttons in the tool section or the settings section. And we have to hold the inspiration for around zero point 0.5 seconds. So at there is minimum airways flow is there, and then the ventilator will derive the P plateau. So in this diagram, we can see what is P plateau. See, the ventilator has delivered a peak pressure because of some airway resistance and the compliance of the lung. The pressure which is reaching up to the alveoli, this is P plateau, and it is derived by doing a inspiratory hold. This is a P plateau. Whenever there is increased resistance in the airway, we may find a large difference between P peak and P plateau. So that has to be kept in mind. And in a volume control mode in which we don't set a P peak, if we find both P plateau and P peak has risen very high, that indicates that the lungs are poorly compliant, and we should keep in mind that poor compliant lung, high pressure may damage the lungs. So this is P plateau, that is alveolar distending pressure. MAP. MAP is the mean airway pressure, or is the average pressure in the respiratory passage during ventilation. It is determined by PIP, peak ventilatory rate, or TI. As we can see in this diagram, it is also called a area under the pressure time graph. So this is the total amount. This is called a MAP, that is mean airway pressure. Typical MAP is kept around 5 to 20 centimeters of water. We don't set a MAP on the ventilator. We derive it by a formula, or a ventilator display unit shows the MAP. So in this diagram, we can see the area under the pressure time graph. The blue one is the area under the pressure time graph, and this is MAP. And whenever we want to increase the mean airway pressure, what we can do, we can increase the flow, or we can increase the peak pressure, that is PIP, or we can increase the total time of inspiration, that is we can increase the inspiratory time, or we can also increase the PEEP, positive and expiratory pressure, or we can increase the respiratory rate. So whenever we want to improve the oxygenation, for oxygenation, the main determinant is mean airway pressure. For increasing the mean airway pressure, either we can increase any of the 5 parameters from this so as to improve the oxygenation. The best one is PEEP. Now, peak inspiratory flow rate, that is tidal volume upon GI, that is maximum speed at which the set tidal volume is delivered by the ventilator. It is expressed in liters per minute. In volume control mode, we can set peak inspiratory flow rate on the ventilator, but in some of the ventilator in volume control mode, we may not find the button of peak inspiratory flow rate. In those ventilators, the peak inspiratory flow rate is set at a default of 60, and it may range. We can set this from 30 to 100 also. The higher the flow rate, the faster the peak airway pressure is reached and the shorter the inspiration. The lower the flow rate we set, the longer will be the inspiration. So we can manipulate inspiration with peak inspiratory flow rate. IE ratio. IE ratio is the ratio of duration of inspiration and the expiratory phase. So whenever we want to set the inspiratory time and the expiratory time on a ventilator, we have to go and see the IE ratio. The normal IE ratio is around 1:2. It can, in some obstructive airway diseases in which we want to have more carbon dioxide to be exhaled, we can have a higher IE ratio, that is 1:3 to 1:4. And in cases in which there is poor oxygenation, we have to increase the inspiratory time, as we have seen in earlier slide that inspiratory time increases the mean airway pressure. So inspiratory time can be increased and the ratio can be around 1:1. Reverse ratio should be avoided. So ideally, whenever we want to set the inspiratory time, it has to be as physiological as possible. That is the inspiratory, that is the inspiratory time should be kept at the physiological age for that age. So we have learned earlier that the respiratory rate of newborns are high, so the inspiratory time is low. So in a newborn, if we see that inspiratory time is around zero point 0.3 to zero point 0.4 second, in an infant it may be around zero point 0.4 to 0.36 second. In children less than 5 years, it is around zero point 0.6 to zero point 0.8 second. In older children and adults, it is around zero point 0.8 to 1 second, and in adults and adolescents or older children, it may be around 1 to 1.1, 1.2 or 1.4 also. So these values, if we are not able to remember, we have to always see the IE ratio. So whenever we are setting the inspiratory time, we have to keep the IE ratio as far as possible around 1:2. So if we want to improve the oxygenation, we can increase the inspiratory time, but by increasing the inspiratory time, it will decrease the expiratory time. Thus, it will decrease the carbon dioxide elimination and may cause air trapping. And this increased air trapping will cause over distension of lung and decrease cardiac output. So these things has to be kept in mind. And whenever we want to improve ventilation, that is, we want to have a carbon dioxide elimination as in obstructive airway diseases like in bronchial asthma in children or in severe bronchiolitis, we may have to have an increased expiratory time. So while setting the expiratory time, we also have to keep in mind that high inspiratory time may cause atelectasis as most of the air has been washed out. So this has to be kept in mind. So two less TI in a if we have set the patient, we have put the patient on a volume control mode, and if we are keeping the two less TI, then this tidal volume is delivered will be too quickly and the pressure will reach too high suddenly and may cause some damage. This things has to be also kept in mind if we keep TI to be too less, and too long TI will limit the respiratory rate, thus resulting hypercapnia as discussed earlier. Now, next one is the phase variable. The phase variables are the variables upon which the ventilator works upon. The three phases, the three most important phases upon which the ventilator works is the trigger, limit, and the cycle. In this diagram, we can see the trigger, what causes the inspiration to begin. There is some there has to be some sensation which the ventilator senses, and it supports that breath or gives the inspiration or starts the inspiration. Second is the limit, this much from the here to here. This is B is the limit. Limit is what regulates the gas flow during the breath. That is in a tidal, in a pressure control mode, we set a tidal volume, and beyond that tidal volume, that the volume will not go throughout the inspiration. And for example, if we have set the patient on a pressure control mode, we set a PIP, and throughout the cycle, the pressure will not go beyond that PIP. So this is the limit. And C is what causes the breath to end. That is this C. We can see in this diagram, C is what causes the end to breath. There are some trigger, the flow is the total volume which has been delivered has ended, or the pressure which has been given and ended. That may be the trigger for stopping of inspiration and start of exhalation. Now let us see one by one the phase variables. The trigger what determines the inspiration. It is of three types: time triggered, pressure triggered, and flow triggered. Time trigger is the breath is delivered once the preset time has been elapsed, that is according to the set frequency. As in controlled mandatory ventilation, we set a frequency. For example, if we have set a frequency of around 20, then the ventilator will deliver the breath at every 3 seconds. So it is time triggered, that is machine trigger. The next two one are the patient trigger, that is pressure triggered, and the flow trigger. So whenever a patient starts inspiration, there is a negative pressure created inside the chest, and this negative pressure or the decrease in baseline pressure is sensed by the ventilator, and now the ventilator helps that inspiratory effort and assists that inspiratory effort by giving a breath at that time. This is called pressure trigger. And flow triggered is the ventilator senses the patient inspiratory effort. How does it sense? By decreasing baseline flow, or it can directly sense the patient inspiratory effort by the flow sensors near the airway opening. The flow sensors, so this is called flow trigger. So both these trigger, the pressure trigger and the flow trigger, is started by the patient. Ventilator senses the patient's inspiratory effort and assists that inspiratory effort by giving a desired PIP or a tidal volume, and various settings which we set. So this is time triggered is machine triggered, pressure triggered, and flow triggered are patient triggered. Now next one is the limit. Limit is what regulates the gas flow during the breath. So for example, if a variable pressure, flow, or volume is not allowed to rise above a preset value during the inspiratory time, then it is called the limit variable. The breath delivery continues, but the variable is held at the fixed preset value. As we have discussed earlier, in a tidal volume, if we have set around 200, then throughout the breath, the volume will not go beyond 200. Or for example, if we have set a PIP as limit, or PIP of around 20, then throughout the inspiratory time, the pressure, that is PIP, will not go beyond 20. So breath is delivered, but the variable is held at the fixed point. The cycle. Cycle is what ends the inspiration. This variable is used as a feedback signal by the ventilator to end the inspiratory flow delivery, which then allows exhalation to begin. It is also of three types: volume cycles, pressure cycle, and time cycle. Volume cycle, for example, if we have set a patient, we have put the patient on volume control mode, and we have set a tidal volume of around 200. The inspiration will end once the 200 tidal volume has reached to the patient. That is, after 200 tidal volume, the exhalation will start if it is volume cycle. And if it is pressure cycle, after a desired pressure, that is, if we have set a PIP of around 20, and after when the 20 airway pressure has reached up to 20, then exhalation will start. Then it is called pressure cycle. And time cycle is inspiration end when the preset time, that is, if we have set a TI of around 0.4 second. So after 0.4 second, the exhalation will start. This is the most common cycling which is used in time cycle is the most common cycling which is used in pediatric ventilator. So most of the pediatric ventilator are time cycled and flow triggered. Time cycle, that is, after a desired inspiratory time which we have set, maybe around zero point 0.4 or zero point 0.6 or 1, the inspiratory time, after that time the exhalation will start. And flow triggered, the ventilator will sense the patient inspiratory efforts, inspiratory flow, and then will assist that inspiratory effort. Now, what are the practical implication of understanding these terminologies? Either we have to increase the oxygenation or we have to improve the ventilation. The cases in which we want to improve the oxygenation are either pneumonia or ARDS, in which lungs are damaged, and oxygenation can be seen by looking at the PaO2 level, or we can look at the SpO2 level. So whenever this PaO2 level is falling, the SpO2 level is falling, we want to improve the oxygenation. Either we can increase the mean airway pressure or we can increase the FiO2. So the mean airway pressure, as we have discussed earlier, it determined by the five variables, that is flow, PIP, that is peak inspiratory pressure, inspiratory time, PEEP, and the respiratory rate. The most important in the determinant of improving MAP is PEEP, that is positive end expiratory pressure. And the second one is to improve the oxygenation is FiO2. Since we don't have to, FiO2 more than 60% is not good for the patient. It may cause oxygen related toxicity. So FiO2 is usually not increased until we have increased the mean airway pressure. Now next parameter which we have to determine is to have a proper ventilation. In cases in which there is poor breathing efforts, the patient has tired, now the patient is not able to respire, or there is CNS involvement and the respiratory center has depressed the respiration, or in case of neurovascular blockage like in GB syndrome, in which ventilation is poor, the PaCO2 level has risen up. And to decrease the PaCO2 level, we either have to increase the tidal volume or increase the respiratory rate. We usually don't touch tidal volume, as increasing the tidal volume will also increase the pressures, and high pressure will not be good for the patient. So whenever we want to improve the ventilation, we usually use respiratory rate to increase. We increase the respiratory rate to cause the carbon dioxide washout. We will see the videos later. Now this is the simple diagram of a ventilator, and we can see here that this is the oxygen supply panel, this is the air supply panel which has to be connected through the central line. So sometimes in new ventilator, there is air compressor attached in the ventilator only, and we don't have to apply the air supply pipeline as is seen in most of the new ventilators. The compressor, inbuilt compressor of the ventilator are available, and then it is a ventilatory display unit. This is a ventilatory display unit. We can see the knobs, button, graphs are there. We have to connect the ventilator to the electric supply. So what electric supply? The three parts has to be given electric supply. That is the ventilator, the UPS, and the air compressor. Whenever we are finding any problem in opening the ventilator, we just have to see whether all these things have been supplied to the electricity or not. This things has to be very kept in mind. Otherwise, we will just land up in calling the technician without any use. So this things has to be seen whenever we are finding any problem in opening up the ventilator. So this is the simple breathing unit. Both is in inspiration. One pipe is for inspiration, one is for expiration. There is a flow sensor. There is HME filter. HME filter is heat and moisture exchange filter. It is used whenever we are not using a humidifier. Whenever we are using a heat and moisture exchange filter, we have to keep in mind that we have to use this HME filter of adequate size, that is of pediatric size. If we are using a larger size HME filter, then it will increase the dead space and decrease the ventilation. And the last one is this one is the test lung. This is given by all the ventilator suppliers. It is used to test whether the ventilator is functioning or not. This is the simple breathing circuit we can see here, and we will show the videos also. This is the patient inlet which is coming from the ventilator. Then there will be a bacterial filter. It is optional. We can or we may not use this bacterial filter. Then from there, the inlet, the inspiratory limb goes into the humidifier. Humidifier, heated and humidification is there. Then in the humidifier, heated and humidifier air comes to the inspiratory limb. Then there is water trap. From the inspiratory limb, there is a Y piece. From the Y piece, it goes to the, either we can connect a nebulizer if we are encountering any bronchospasm, or if the child is of bronchial asthma, we can set up nebulizer in between the Y piece and the flow sensor. Then from the, or if we don't require, we have to remove this nebulizer. Then there is a flow sensor which is connected to the Y piece, and then HME filter. We are not using the humidifier. And then from HME filter, either we can connect directly to the NIV mask, that is a BiPAP mask, we can connect it, or we can connect to the ET tube, endotracheal tube. From the patient, the exhaled air goes to the Y piece through the expiratory limb, and then to the exhalation wall to the ventilator. So this is a simple breathing circuit through which a ventilator works. Whenever, if we want to apply, how to apply this breathing circuit, although it is very simple, and we will be showing the videos also, but if we don't know how to apply, the technician during installation will come and tell how to apply this ventilator breathing circuit. So this is a simple ventilatory display unit. We can see this is the on-off button. This is alarm. This is a rotatory knob. This rotatory knob is used to change the various settings which have to set on the ventilator. That is, this blue squares are for the settings which we set on the ventilator, and this black squares are the setting which is derived by the ventilator. So this is a, see, this is a pressure control mode, and we have got a tidal volume. So we have to always see whether the patient is receiving the adequate tidal volume according to the weight or not. And this is the FiO2 which the patient is being delivered, and the ventilator is deriving it. And these are various flow graphs, that is pressure time graph, flow time, volume, and we have pressure volume graph also. And there may be some buttons in which we can change this graphs also. These are the references of this talk, when you can go and see these references for more detailed learning. skills to be enhanced are, it is important to understand and set all these parameters, as these are the basic parameters which we set on the ventilator. Changes in these parameters should be done according to the patient's clinical status. The patient may be improving, the GC may be improving, and the arterial blood gas report which we studied earlier. Further practical implication will be discussed in the mode section, and the initial setting and titration will be also taken in the further lecture. My sincere thanks to all the contributor which has contributed to the very simple and the beautiful module of pediatric COVID training. And my thanks to Shali ma'am, Chandrakanta ma'am, and DGME sir, all the panelists. My sincere thanks to all the participants for keen learning and listening to me. Now I will be showing some of the videos how to set up a ventilator. Mamta team, can you play the videos, please? Mamta, Mr. Neeraj, yes, last three.
वेंटिलेटर है और ये हमने इसमें सर्किट और टेस्ट लैम्प तैयार करके रखा है। मैं आपको दिखा दूँ, ये फ्रॉम द पेशेंट दैट इज एक्सपिरेशन एंड ये टू द पेशेंट दैट इज इंस्पिरेशन। ये फ्लो मीटर के लगे हुए हैं, ये वेरी सिंपली अटैचेस हेयर है स्पायरोमेट्री को, ये यहाँ लगे हुए हैं स्पायरोमेट्री। ये लाइन यहाँ अटैच्ड है, यहाँ पे हमने फिल्टर अटैच कर रखा है और ये टेस्ट लैम्प अटैच्ड है। अब मैं आपको बताऊंगा कैसे इस वेंटिलेटर को आपको ऑन करके चलाना है, यूज़ करना है एग्जैक्टली। तो इस वेंटिलेटर में आपके पास दिस इज द कंप्रेसर एंड दिस इज द यूपीएस। इन दोनों को बिजली की सप्लाई देनी है, करंट की सप्लाई देनी है, और ये है वेंटिलेटर। इन तीनों को करंट देना है हमको। वेंटिलेटर अपना करंट यूपीएस से उठाता है, तो वेंटिलेटर का जो सर्किट है वो यूपीएस में लगा हुआ है। कंप्रेसर और यूपीएस, इनका कनेक्शन हमने यहाँ दे रखा है। ये यूपीएस के लिए है, ये कंप्रेसर के लिए है, और वेंटिलेटर की इलेक्ट्रिक करंट वो यूपीएस से आ रहा है यहाँ पे नीचे इस पॉइंट से। ठीक है, तो आपको दो आउटलेट लगाने हैं और वेंटिलेटर का इनलेट आपको यूपीएस से लेना है। अब इसको कैसे ऑन करना है? ऑन करने से पहले मैं इसे ऑफ कर देता हूँ। वेंटिलेटर बंद हो गया। ठीक है, आपने कनेक्शंस दे दिए, आपने बटन ऑन किए। आप आएंगे यहाँ पे, पहले बटन को ब्रीफली प्रेस करेंगे। पहले यहाँ से कंप्रेसर को ऑन करेंगे और यहाँ से फर्स्ट बटन को ब्रीफली प्रेस करेंगे फॉर 10 सेकेंड्स। यहाँ पे आ जाएगा वोल्टेज 230 वोल्ट्स का। वेंटिलेटर की मेन स्क्रीन पे आएंगे, यू विल कंप्रेस इट, सेल्फ टेस्ट एंड कैलिब्रेशन होगा। पास नॉब को प्रेस करेंगे, स्टार्ट दबाएंगे, स्टैंड बाई मोड पे है। अपना मोड सेलेक्ट कर लेंगे, आप जो भी मोड यूज़ करना है आपको। सपोज आपको हमें पीसीपैप मोड यूज़ करना है, अपने मोड के लिए आपने स्टार्ट कर दिया और इंश्योर करना पड़ने के लिए कंफर्म कर देंगे, ये स्टार्ट हो।
Hello everyone, today we will see about the mechanical ventilator, the parts of the ventilator, tubings, how to attach these tubing and how to start a ventilator, and the next part we'll see how to set the parameters for the pediatric patient. So this is the electronic ventilator which we are using in our ICUs. This is the main panel of the ventilator. Currently this is switched off. We have to switch on the ventilator from the back side. After connecting the charging port into the cable into the charging port, and also the humidifier, and we'll connect the cable of the humidifier in the port, and we'll start the ventilator. This we'll see the charging cable lights of the charging cable are on. This is the button from which will start the ventilator. We'll press it for the long time and we'll see the main panel is getting displayed. It will take some time to for the main screen to come. Till the meantime we'll attach the tubings. So as all the ventilator we know, we have some basic tubings. We'll take the sterile tubing, either the fresh tubing which are coming in the market or the reusable tubing which have been ETO'd or sterilized. So after donning gloves and hand washing and donning gloves, we'll take out the tubing. This part which has a 3 plug, this is the expiratory tube. So these are the tubings. It has both inspiratory and expiratory part. So how to differentiate? The one with a thin, the white tubing generally with a thin inlet is the expiratory tube, and the blue one, other one is the inspiratory tube. So as we see, this is the attachment which goes on the patient end in the endotracheal tube, and this is the end which goes into the ventilator. So we'll start with the humidifier chamber. So this is the humidification chamber, which will, as we can see, there is a line which gives us the level for the water, and only sterile water or distilled water is filled in the chamber. So this is our humidifier. We'll switch on the humidifier from this point. We'll push down the inlet and then gradually slide it down. So as a click sound has come, that means the chamber has properly fixed. Now we'll attach the tubings. So this port, this is expiratory port, and this is clearly mentioned here is expiratory. So the expiratory port will goes into this. The second part, which is the short part of the inspiratory tube. So the one part goes into the inspiration as mentioned in here, like this, and the broad part goes into the humidifier chamber. So we'll put the humidifier chamber. This is the inspiratory port which is going from ventilator to humidifier. Second part will come from humidifier to the patient end. So this is the second part of the inspiratory lamp. From humidifier, the broad end will goes into the humidifier chamber, and the second part into the patient lamp. For timing, we'll attach the patient lamp to the test lamp. There is one more tube which is oxygen tubing. This is attached from this proximal end of the ventilator up to the distal end of the expiratory limb. This is the point. Okay, so this is our tubing. Now comes the humidification. So for the how to attach the humidifier, since we have seen, we have switched on the humidifier, it is showing us the temperature. These are two modes, the invasive mode and non-invasive mode. Since we are doing the invasive ventilation, we'll select the invasive mode, and these two wires are there. So where to connect which wire? Since there are 3 ports, as you can see, we'll connect this proximal end into the inspiratory one, like this. The second part goes into the expiratory limb here, upside. Now the second tubing, the below one, as you can see, it has a blue point and has a cone-like thing here. So this cone get attached into the inspiratory limb. As you can see, there is a conical part for this blue thing. So we'll attach it here like this. Next comes its distal part. This is conical form, and this get attached into the inspiratory limb. So our inspiratory limb is humidified and heated. Now coming to the ventilator. So after attaching to the main source, we'll attach the air and oxygen. So from behind, please come behind. So and on the back side of the ventilator, as you can see, it's clearly mentioned the oxygen port and the air port. So when we'll trace down the air port, this white port is the oxygen port. So as we'll see, this white tubing will connect into the oxygen like this. We have to plug it down and then push. Similarly, air, we'll plug it down and push. Second thing which we'll see on the back side is the flow sensor. So from here the flow sensor wire is connected and it is then connected on the patient end like this. Now we'll start the ventilator. As we have switched on, this is the first screen which we see on the ventilator panel. We'll see the audio test. It is making sounds. Yes, we are able to hear the sound. Now here comes the second screen. Now we have to select which are we dealing with the pediatric, like neonatal age group or pediatric age group. So if we are here dealing with the neonatal age group, less than 10 kgs, well, and it's about the flow sensor. So how to calibrate the flow sensor? So we'll take the flow sensor, we'll block both of its end or with our palm and then do the flow calibration. So as you can see, a green line has came and is saying it's calibrated. We'll go on the main screen. We'll connect it back. So this is the main panel. On main panel you can see there are multiple things which is coming and these are the modes. On baseline you can see there CPAP, nasal CPAP, dose CPAP, oxygen therapy. These are basically non-invasive modes, and the upside is control mandatory ventilation, assist ventilation, SIMV, SIMV plus PSV and PSV. These are basically the invasive modes which we can give in the patients. Depending upon the modes, there are the control panel, there are the parameters which we can control, like the flow, trigger, I time, E time, the frequency, this FiO2, PIP and PSV, PEEP, oxygen and volume limit. And this is the graph we can see depending upon what parameters we are seeing, whether the pressure, volume or flow. So one by one I'll tell you what settings which we are needed to set for different parameters.
Thank you, Mamta team. I think most of the modes and the initial setting will be discussed in the coming lecture with which the questions has been asked. A more detailed talk will be there by Dr. Thapar on the modes, and the initial setting and the titration will be done by Dr. Yashwant Rao in the coming session today only. So we'll not discuss that so that we stay with the time. And the hands-on training, maybe I think some of the hands-on training maybe will be done sometimes later. And in one of the question was how much PEEP in newborn. So PEEP is in either pediatrics or newborn, it's 3 to 5 only. The minimum is 3 to 5 in the patient. Whenever the patient is not requiring this much of high PEEP and all the setting are in the lower limit, then we can wean the baby. So this is the minimum which we keep, that is 3 to 5. Thank you very much. Now, any other question? I don't think there are much questions there. Now I will proceed to the next session, that is multi-para monitoring. Multi-para monitoring will be done by Dr. Anupama Verma, Associate Professor from LLRM Medical College, Meerut. Over to you, Dr. Anupama.
Thank you, Manisha ma'am. Good afternoon. Good afternoon to all the attendees. I'm sharing my screen, ma'am.
Yes, it's visible, but still slideshow is not there.
Ma'am, now.
Yes, it is visible.
Ma'am, is my slides? Yes, ma'am. Okay. Thank you, ma'am. For the next 30 to 40 minutes, we will be talking about the multi-para monitors. What should be our learning objectives? It will be what are the different monitoring parameters we will be using in monitors, how to use, what should be our alarm settings, and one of the important aspect of using any machine is the maintenance of the machine. First, what is multi-para monitoring? It is a simultaneously measure and display of relevant vital parameters in a sick child. उसी टाइम पे मेजर कर रही होगी मशीन, उसी टाइम में आपको डिस्प्ले हो रहा होगा either in numeric or graphic or both. In general, basic models are used to measure cardiac activity, heart rate, oxygen saturation, both invasive and non-invasive blood pressure, respiratory rate, and temperature. It consists of 4 components. First of all, sensor, which is attached to your body. Then there is a communication link. Then there is a processing device, and finally a display. Additional specifications are according to the model and maker, and there are multiple brands available in the market. Some examples are like Milray, GE, Draeger, Silverline, etc. Now, what should be our monitoring domains? In cardiology, we have different domains like ECG, cardiac output, continuous cardiac output monitoring, impedance cardiography. For hemodynamic oxygenation and volumetric, we have invasive and non-invasive blood pressure, central venous saturation, SpO2, perfusion index. For airway and lung mechanics, we have respiratory mechanics. Tissue perfusion, we have regional saturation. For neurology, we have EEG and neuromuscular NMT and temperature. These red ones are the common parameter. We will be taking up one by one in the next slides. The common ones are the ECG, respiratory rate, saturation, temperature, blood pressure, both non-invasive and invasive, central venous pressure, and EtCO2. Other parameters which are not commonly used are EEG, regional oxygen saturation, cardiac output, continuous cardiac output monitoring, central venous oxygen saturation, neuromuscular transmission, impedance cardiography, bispectral index, respiratory mechanic, and transcutaneous blood gas. We will be taking the first parameter, that is ECG. ECG can be monitored by using either 3 lead, 5 lead, 6 lead or 12 lead selectable. तो अपनी ease के हिसाब से हम कोई सा भी lead से हम ECG monitor कर सकते हैं. We get heart rate from the ECG leads, and arrhythmia detection is very easy just by looking at the waveform of the ECG. We can diagnose many electrolyte imbalances just by looking at the waveform of ECG. Now, where should we place the 3 lead? At least a 3 lead electrode placement सबको आना चाहिए. तो वो 3 जो आप electrode place करेंगे, वो कहाँ पे place करने हैं? तो 3 values होती हैं, RA, LA and LB. RA कहाँ पे होता है? It is on the right side below the clavicle near the right shoulder. LA is below the clavicle near the left shoulder. LL कहाँ लगाना है? LL is in left lower abdomen. तो कोई भी पेशेंट जैसे इमरजेंसी में लैंड करता है, आपको एकदम से उसके एटलीस्ट 3 लीड कनेक्ट करके आप ईसीजी केबल उससे कनेक्ट कर दीजिए, तो आपका जो नीचे जो आ रहा है दैट इज द बेसिक ईसीजी रिदम आने लग जाएगा और एक हार्ट रेट आपका आने लग जाएगा. तो इनिशियल मॉनिटरिंग आपकी तभी स्टार्ट हो जाएगी. नेक्स्ट डोमेन इज रेस्पिरेटरी रेट. We derived respiratory rate either by the CO2 monitoring or by the impedance using the same ECG lead. जो ECG lead आपने heart rate के लिए लगाई है, उसी से आपकी respiratory rate भी monitor होगी. Either lead 1 or lead 2 is used to monitor the respiratory rate. Lead 1 क्या होती है? Lead 1 is lead connecting the RA and LA. जो ऊपर वाले दोनों हैं, RA और LA को जो connect कर रहा है, that is lead 1. Lead 2 क्या है? Lead 2 is connecting the RA and LM. Either of this lead can be used to monitor the respiratory rate. Next important domain is pulse oximetry, which is most talk about. कि सबको पता है कोविड एरा में कि saturation क्या होता है, what is SpO2, oxygen level कितना होता है, तो ये even layman knows about it, about the saturation. Other parameters except other parameters with saturation is perfusion index. PVI is plethysmography variability index, and SIQ is signal IQ indicator. We'll be taking up one by one. In the pictorial this is the pictorial representation of this SpO2 probe which is available in the market. तो अलग-अलग तरह का click form में हो सकता है, band form में हो सकता है. तो ये अलग-अलग हैं जो probe available है markets में. First, SpO2. What is SpO2? It is measure of oxygen saturation. Our target saturation in pediatric age group will be 92. 94 हम adult age group में ले रहे थे, पर pediatric में हम 92 use करेंगे as a target saturation. At the same time, we should avoid hyperoxemia in newborns. तो newborns में भी जो आपका saturation रहेगा, इतने पे ही रहे. Hyperoxemia we should always avoid. There is a numeric and a graphic display of saturation, and probe placement should be in the right upper hand in the neonates. तो pre-ductal positioning होनी चाहिए आपकी इसकी probe की. And we should avoid taking saturation in which BP is being measured. जिस हाथ में आपने BP कप को बांध दिया, उस हाथ में आपको सैचुरेशन प्रोब अटैच नहीं करना है. इसका रीजन यही है कि आपका बीच बीच में बीपी के लिए इन्फ्लेट होगा ब्लैडर, वो आरटी को कंप्रेस करेगा और आपकी रीडिंग जो फाइनली डिस्प्ले हो रही है उस पे वो फॉल्स रीडिंग हो सकती है. तो अननेसेसरी अटेंशन आपका बार बार उस फॉल्स रीडिंग पे जाएगा. तो वी शुड ऑलवेज avoid attaching a sensor in which the BP is being measured. And changing of probe site is also very important, and ear probes are also available. Where the perfusion is very poor and we are not getting reading by the sensor which is attaching to the peripheries, we can use ear probes in that patients. Next important term is perfusion index. एक थोड़ा basic idea दोनों terms के बारे में होना चाहिए. Perfusion index क्या होता है? What is plethysmography variability index? Perfusion index is a indicator of peripheral blood flow. Periphery में आपका कितना blood flow हो रहा है, that is indicated by the perfusion index. It is a measurement of the strength of plethysmography signal at a sensor site. It compares pulsatile to non-pulsatile signal. और इसकी जो वैल्यू होगी वो इट रेंजेस फ्रॉम 0.02% टू 20%. तो 0.02 का क्या मतलब होगा कि वेरी वीक पल्स स्ट्रेंथ इज देयर. तो जो पेरिफेरी जो फाइनली पेरिफेरी में जो सिग्नल को रीड कर रहा है जो वो है दैट इज वेरी वीक. और 20% अगर पीआई की वैल्यू है तो उसका उससे क्या इन्फ्लुएंस निकलेगा, दैट मींस इट वेरी स्ट्रॉन्ग पल्स इज देयर. What is PVI? PVI is plethysmography variability index. It measures change of perfusion index during a respiratory cycle. And it is measured by maximum minus minimum upon maximum multiplied by 100. And basically PVI वहाँ use होते हैं जहाँ fluid boluses आपने दिए हैं तो indicate आपको further fluid bolus देना ही नहीं देना. It is also helpful in that case. PVI more than 14% show response to fluid low and can predict fluid responsiveness in infants undergoing congenital heart surgeries. तो ये monitor एक बना हुआ है, उसमें जो blue color का there is circle 1.1, this is perfusion index value जो आपके monitor में display होती है, that is 1.1 perfusion index. Next important parameter in saturation is SIQ. एक SIQ और होता है साथ में, that is signal IQ indicator. What is it? It is a quality of flow to the area applied and hence the signal quantity. जो आपका सिग्नल है वो एक्चुअली कितना मतलब ठीक आ रहा है नहीं आ रहा है वो उससे आप SIQ वैल्यू से आप देख सकते हैं. तो इसका बेसिकली जो होता है दैट इज अ ग्राफिक डिस्प्लेशन जो रेड सर्कल में नीचे है. इसमें क्या है, देयर इज अ हॉरिजॉन्टल लाइन एंड देयर इज इंटरमिटेंट वर्टिकल लाइंस होती हैं. तो वर्टिकल लाइन से हर एक वर्टिकल लाइन एक आर्टेरियल इंपल्स को डिपिक्ट करती है. तो अगर ये रेगुलर इंटरवल पे देयर इज वर्टिकल लाइंस तो इट शोज इट इज टेकिंग अप एवरी इंपल्स एट रेगुलर इंटरवल. तो ये मतलब ये नॉर्मली आप जब रीडिंग इंटरप्रेट करते हैं तो आपको इस साथ में एक SIQ इंडिकेटर भी देखना चाहिए. आई विल गिव यू फ्यू एग्जांपल, यू विल अंडरस्टैंड बेटर बाय लुकिंग अप दीज एग्जांपल्स. इसमें 4 हैं. सबसे पहले सबसे ऊपर वाला देखते हैं. सबसे ऊपर वाले में क्या है, देयर इज अ प्लेथिस्मोग्राफी ऊपर और एक नीचे सिग्नल IQ इंडिकेटर है. अगेन देयर इज अ हॉरिजॉन्टल लाइन और इंटरमिटेंट वर्टिकल लाइन है. साथ में 95 सैचुरेशन दिख रहा है, 1.06 इज परफ्यूजन इंडेक्स, 179 इज द हार्ट रेट जो मॉनिटर में आपका डिस्प्ले हो रहा है. तो आपका इन्फ्लुएंस क्या निकलेगा, देयर इज गुड रेगुलर है तो गुड प्लेथिस्मोग्राफी along with the good signal IQ इंडिकेटर. ये सिग्नल IQ इंडिकेटर बिल्कुल ठीक है. नेक्स्ट वाले में देखते हैं, इससे नेक्स्ट सेकंड वाला जो है, देयर इज इरेगुलर दिस प्लेथिस्मोग्राफी अलोंग विद सिग्नल इंपल्स आ ही नहीं रही है, वो ले ही नहीं रहा है, तो वर्टिकल लाइंस आपकी है ही नहीं. तो आपकी इन्फ्लुएंस क्या होगा, देयर इज इनकंक्लूसिव प्लेथिस्मोग्राफी अलोंग विद पुअर SIQ. पुअर सिग्नल इंडिकेटर इज वेरी पुअर. तो जो ये रीडिंग डिस्प्ले हो रही है 94, 1.83, दीज रीडिंग में बी अ फॉल्स रीडिंग. तो इन रीडिंग को इंटरप्रिटेशन हमेशा मतलब पहले आप अपना देख लीजिए, सिग्नल IQ इंडिकेटर आपका ठीक आ रहा है तब भी आप उस वैल्यू को इंटरप्रेट करेंगे. थर्ड वाले में देखते हैं. थर्ड वाले में देयर इज दिस वेरिएबल प्लेथिस्मोग्राफी अलोंग विद, ये सिग्नल IQ इंडिकेटर इसमें ठीक है, अच्छे से एक हॉरिजॉन्टल लाइन है और इंटरमिटेंट वर्टिकल लाइन है. तो दीज मे बी ट्रू वैल्यूज. लास्ट वाले में क्या है, सिग्नल IQ इंडिकेटर तो बहुत अच्छा दिख रहा है पर देयर इज लो वॉल्यूम प्लेथिस्मोग्राफी. तो आवर इन्फ्लुएंस विल बी good signal IQ indicator along with non-variable low plethysmography. So these are the few example of signal IQ indicator. Next important monitoring domain is temperature. Thermally sensitive resistors are used to get the temperature reading. The resistance change of thermistors are used to calculate the temperature. Up to 2 sites can be monitored simultaneously, and difference between the 2 sites is calculated. Rectal temperature monitoring is also possible by the spatial probes, and these are usually done in severe hypothermia, in malnourished, severe acute malnourished patients. Next important parameter is non-invasive blood pressure. Non-invasive blood pressure is taken up by the oscillometric method. It is based on the principle that the pulsatile blood flow through an artery creates an oscillation of the arterial wave. जब भी वो artery के through blood flow होता है, एक oscillation produce करता है. Oscillations को ही वो read करेगा, interpret करेगा by this blood pressure. तो आपकी 3 values होती हैं जब भी आप non-invasive blood pressure लेते हो. एक तो mean blood pressure होता है, systolic blood pressure, and there is diastolic blood pressure. Machine actually measures the mean blood pressure by the oscillation. जितना oscillation हो रहा है आर्टरी में, उसको जो measure करके वो mean blood pressure देगा आपको, और systolic and diastolic blood pressure are derived from it. तो इसमें बीच में oscillation है, बीच वाला है, that is mean blood pressure. What important point we should keep in mind while taking the BP, क्योंकि वही है जो value है, सबसे important ये है कि आप जो cuff size use कर रहे हैं, that should be appropriate to the child. Maximum error इसी में आती है कि आपका cuff size appropriate नहीं होता है, तो we should be very cautious while selecting the size of BP cuff. We should first of all determine the limb circumference from the acromion to the olecranon process. Mid point पे उसमें arm circumference लेना है. The width of the cuff should be 40% in units and 2/3 of the length in the upper arm and thigh or thigh in children. The inflatable portion, that is the bladder part, should cover 60 to 80% of the arm. And application of the cuff should be such that the artery marking should be at appropriate place. एक एरो का मार्क होता है ज्यादातर कफ में, तो आपका आर्टरी की पोजीशन पे ही वो एरो आना चाहिए. It should be smooth and snugly fitting. तो बहुत ज्यादा टाइट आपको बैंड नहीं बांधना है, ना ही वो लूज होना चाहिए. And we should choose auto deflation mode. Ideally, average of 3 readings should be taken, and we should avoid taking BP in crying or agitated child. Unnecessary, क्योंकि आपका बढ़ा हुआ BP आ सकता है in crying and agitated child. These are the pictorial representation of various neonatal disposable cuffs available in the market. अलग-अलग sizes के होते हैं, इसके ऊपर sizes भी होते हैं 1 to 5 ये है. सबसे छोटा वाला size is 1 है, सबसे बड़ा वाला cuff size जो है this is size number 5. Next is invasive blood pressure monitor. क्योंकि critically ill patients में sometimes oscillometric by monitoring blood pressure by the oscillometric method can give the false reading. So invasive blood pressure monitoring is generally done in critically ill patient. Real-time monitoring is where real-time monitoring is required, and both numeric and waveforms can be taken up from the invasive blood pressure monitoring. This is pictorial representation of invasive blood pressure. कैसे है, आपको एक arterial line चाहिए basically invasive blood pressure monitoring के लिए, तो एक arterial line होगी. Number 5, this is 3-way valve. वहाँ पे एक 3-way valve connect होगा, जो further एक 3-way valve फिर और होता है, एक transducer. Number 4 is transducer होता है वो. Transducer is connected to the IB cable. Cable is connected to module. Module is there placed in with the multi-para monitor. Monitor के अंदर ही आपका ये module अलग है, जो भी आप monitor कर रहे हैं तो अलग-अलग modules fit होते हैं आपके multi-para monitor में. तो number 2 is module. Number 1 is this is pressure bag filled with normal saline. तो ये आपका वो है, तो ये है, और इसका जो है this is a picture of this. Again, pressure bag filled with normal saline. Then it is connected to the IV line, and this is connected to transducer. Transducer से cable attach है, और cable जो red वाला part है, this is cable, और cable finally module में attach हो जाता है, जो कि multi-para monitor में लगा हुआ होता है. Important points while taking the invasive blood pressure: soft patency, soft tubing of bag of NaCl containing 500 flush solution placed in pressure bag should be inflated to 300 millimeter of mercury. Leveling is very important to minimize the effect of hydrostatic pressure on the transducer. If it is too high, there will be lower pressure, abnormally low pressure will be there. If it is too low, greater pressure will be there, and it will give us abnormally high pressure. Zeroing is done to negate influence of external pressure on the monitoring system. जो बाहर का atmospheric pressure या कोई और pressure है वो आपके value को interfere ना करे. These are the components of arterial waveform. There are four components of it. Number one is the systolic blood pressure, and number three is the diastolic blood pressure, and two is the dicrotic notch produced by this closure of the aortic valve. Next important parameters is end tidal CO2. Saturation actually सबको पता होता है कि saturation देखना होता है. Saturation actually measures the this oxygenation of the body. And what is EtCO2? It is a measure of the ventilation of the body. तो actually जो alveolar arterial alveolar junction पे जो आपका exchange of gases हो रहा है वो ventilation part है. That is depicted by the EtCO2 value. So it is also one of the important component for monitoring the patient. What is capnography? Capnography is a graphic display of CO2 concentration versus time. उसे time capnography बोलेंगे. अगर उसी को against expired volume ले लेंगे तो उसे volume capnogram बोलेंगे during a respiratory cycle. Capnography is a graphic display. Capnograph machine वो है और जो हमें finally waveform जो मिलेगी उसे बोलेंगे capnogram. Capnogram actually आगे slide में है. It is a rectangular waveform which will be shown in the next slide. What is capnography depicts? It depicts the CO2 production from the body. How the CO2 is produced? It is produced by this metabolic oxidation process. CO2 cellular level पर produce होती है by the mitochondria and then it is taken up by the circulation. Pumping से right से left में जाएगी and then it is taken up by through circulation. It is taken up by the lungs. Lungs से finally वो बाहर आ जाती है. Exhalation के through बाहर आएगी. तो finally it will give you the value. तो EtCO2 की जो value इसमें दी हुई है this is 34, respiratory rate is 50 और जो rectangular waveform है this is capnogram. We can get capnography by two ways. एक तो ये है कि आप सीधे ET जो endotracheal tube है आप उसमें सीधे सेंसर कनेक्ट कर दीजिए उसे बोलेंगे मेन स्ट्रीम कैप्नोग्राफी. एक ये है कि आप वहां पे अडेप्टर अटैच कर दीजिए और साइड में सेंसर और डिस्प्ले होगा. दिस इज साइड स्ट्रीम कैप्नोग्राफी. तो दो तरीके से हम अपना सेंसर अटैच कर सकते हैं आइदर डायरेक्टली और बाय अटैचिंग अ अडेप्टर. This is normal this capnogram. Capnogram actually just by looking at the capnogram ये आपके उसमें अगर आपने मॉड्यूल लगाया हुआ है EtCO2 का आप सेंसर से अटैच कर दिया तो एक बेसिक वेवफॉर्म आपके मॉनिटर पे डिस्प्ले होता रहेगा. एक थोड़ा सा भी बेसिक आइडिया अगर हमको EtCO2 का वेवफॉर्म का है तो हम बहुत सारी चीजें डायग्नोस कर सकते हैं जस्ट बाय लुकिंग एट द वेवफॉर्म. तो वी कैन टेक वेरियस स्टेप जस्ट बाय लुकिंग एट द ग्राफ. तो बिल्कुल बेसिक से स्टार्ट करते हैं. कैसे दिखता है ये EtCO2 का जो वेवफॉर्म है? रेक्टेंगुलर शेप का है. 4 फेजेस हैं. फेज 1, 2, 3 एंड 0. सबसे पहले इसमें 2 कलर्स से डिपिक्ट करा हुआ है येलो एंड व्हाइट. व्हाइट पार्ट इज इंस्पिरेशन, येलो पार्ट इज एक्सपिरेशन. ठीक है. तो हमारा जो CO2 प्रोड्यूस हो रहा है वो एक्सपिरेशन में जब बॉडी से बाहर निकलेगी एयर उसमें आएगा CO2. तो एक्सपिरेशन पार्ट विल डिपिक्ट तो येलो पार्ट. तो सबसे पहले फेज 1 पे चलते हैं. तो फेज 1 इज फ्लैट. यहाँ पे व्हाइट पार्ट खत्म हुआ, येलो पार्ट स्टार्ट हुआ. तो दैट इज स्टार्टिंग ऑफ एक्सपिरेशन. When there is starting of expiration, initially there is clearing of dead space. Dead space से आपका पहले निकलता है तो वहां पे कोई CO2 नहीं होता क्योंकि there is no exchange in the dead spaces. तो वहां पे कोई CO2 नहीं है. तो this graph will be flat. Then comes to this phase 2. फेज 2 में क्या है? आपकी जितनी डेड स्पेस की तो क्लियरिंग हो गई, उसके बाद एल्वोलाई की जितनी भी एयर है वो ऊपर आएगी. तो देयर इज अ रैपिड राइज. क्योंकि ऑब्वियसली एल्वोलाई में ही एक्सचेंज में से आपका CO2 है तो एल्वोलाई वाला ही CO2 सारा आपका बाहर आएगा. तो देयर इज रैपिड राइज ऑफ CO2 एज एयर फ्रॉम एल्वोलाई कंटेनिंग CO2 रीचेस द अपर एयरवे. तो दिस इज फेज 2. फेज 3 में क्या है? देयर इज इसे बोलते हैं एल्वुलर प्लेट्यू. एक प्लेट्यू फॉर्म हो जाता है जो कि एक मैक्सिमम आपका CO2 पहुंच गया और दिस इज कॉल्ड एल्वुलर प्लेट्यू. एक्चुअली जो हाइट होता है इसका एल्वुलर प्लेट्यू का इट ऑल्सो डिपिक्ट्स द कार्डिक आउटपुट. आप ना कार्डिक आउटपुट पेशेंट का कितना चल रहा है आप उसका भी एक आइडिया लगा सकते हैं जस्ट बाय लुकिंग एट दिस हाइट ऑफ दिस प्लेट्यू. फिर एट द एंड ऑफ एक्सपिरेशन, जहां पे ये एंड है, ये हमने सर्कल कर रखा है ब्लू से, दिस इज एंड टाइडल CO2 रीडिंग। एंड टाइडल मतलब खत्म हो गया एक्सपिरेशन, तो ये जो सेंसर जो हमारी रीड कर रहा है वो ये ही वैल्यू को लेगा। दिस इज एंड टाइडल, खत्म हो गया एंड टाइडल पार्ट को, दिस वैल्यू विल बी टेकन अप बाय द सेंसर एंड विल शो ऑन इन आवर मॉनिटर। तो देयर इज एंड ऑफ एक्सपिरेशन एंड स्टार्टिंग ऑफ इंस्पिरेशन। इंस्पिरेशन में कोई भी CO2 क्लीन नहीं होता, तो देयर इज अ रैपिड डिक्रीज इन द दिस ग्राफ फॉर्म। तो व्हाइट पार्ट आ गया, दिस इज इंस्पिरेशन, तो इसमें CO2 आपका एकदम से नीचे चला गया। तो दिस इज नॉर्मल कैप्नोग्राम। अब कुछ और एग्जांपल्स ले लेते हैं फॉर द बेटर अंडरस्टैंडिंग। दीज आर द फ्यू एबनॉर्मल, वो जो हमने देखा दैट इज नॉर्मल कैप्नोग्राम, जो हम लोगों का आएगा नॉर्मल कैप्नोग्राम। अब कुछ है, सबसे पहला वाला वेव फॉर्म देखते हैं। सबसे पहले वेव फॉर्म में क्या है, पहला तो बिल्कुल वैसा ही है जैसे हमने अभी देखा, नॉर्मल प्लेट्यू आया, फिर सेकंड वेव, फिर एकदम से गायब हो गया, कोई CO2 ही नहीं आ रहा हमारी बॉडी से। तो व्हाट इट मींस देयर इज सडन लॉस ऑफ वेव फॉर्म, आइदर द ईच ट्यूब इज डिस्कनेक्टेड, डिसलॉज और किंक्ड। ठीक है, या तो हिल गई अपनी जगह से या वो ब्लॉक पड़ी हुई है। और एम्पलीट्यूड भी नहीं आ रहा है आपका ना, एम्पलीट्यूड, व्हाट एम्पलीट्यूड डिपिक्ट्स जो हाइट ऑफ दिस वो जो उसका फेस था, इट मींस देयर इज लॉस ऑफ सर्कुलेटरी फंक्शन। तो आइदर ऑफ दीज, या तो आपकी ईटी ट्यूब डिसलॉज कर गई है या आपका सर्कुलेटरी फंक्शन बिल्कुल ही चला गया है। सेकंड में देखते हैं सेकंड वेव फॉर्म। सेकंड वेव फॉर्म में पहला वाला ठीक है, फिर देयर इज डिक्रीज 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 डिक्रीज, तो धीरे 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 वेव फॉर्म का जो एम्पलीट्यूड है कम होता चला जा रहा है। तो इसमें भी सेम है कि कुछ CO2 तो आ रही है, पर एक्चुअली जितनी आनी चाहिए उतनी नहीं आ रही है। तो आइदर द ट्यूब, देयर इज अ लीक इन ट्यूब, or either the tube is in hypopharynx or there is a partial obstruction of our AT tube. थर्ड को देखते हैं। थर्ड में क्या है, there is this is during CPR, अगर हम CPR करें किसी पेशेंट का, just by looking at the capnogram we can assess कि जो हम उसे कार्डिक कंप्रेशन, चेस्ट कंप्रेशन जो दे रहे हैं वो एडिक्वेट है नहीं है। अगर आपका एडिक्वेट चेस्ट कंप्रेशन है, देयर शुड बी एटलीस्ट this increase of this plateau of 10 millimeter of mercury। तो इसमें आपका CPR असेसमेंट के लिए यूज किया हुआ है कैप्नोग्राम का। तो एटलीस्ट 10 मिलीमीटर का अगर आपका दिस प्लेट्यू आ रहा है, तो दैट मींस वी आर डूइंग अप्रोप्रिएट CPR। लास्ट वाला इस रो में देखते हैं, देयर इज कुछ है एकदम से बहुत सारा इंक्रीज हो गया, तो व्हाट इट इज टर्म्ड एज, इट इज रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन। तो एकदम से आप CPR कर रहे थे, आपका स्पॉन्टेनियस सर्कुलेशन आ गया पेशेंट के ना, स्पॉन्टेनियस रेस्पिरेशन या ऑक्सीजनेशन जो है एकदम से इंप्रूव करा, तो आपका EtCO2 में एकदम से चेंजेस आएगा। तो दिस इज डिपिक्शन ऑफ रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन। नेक्स्ट रो में आते हैं, देयर इज दिस इज कॉल्ड शार्क फिन अपीयरेंस, दिस इज टिपिकली सीन इन asthma and COPD। नेक्स्ट वाले में देयर इज डिक्रीज इन फ्रीक्वेंसी, इट मींस देयर इज हाइपोवेंटिलेशन। अगले वाले में देयर इज इंक्रीज इन फ्रीक्वेंसी, इट मींस देयर इज हाइपरवेंटिलेशन। लास्ट वाला देखते हैं कैप्नोग्राम। लास्ट वाले में क्या है, दिस इज नॉर्मल, फिर थोड़ा सा डिक्रीज हो गया, फिर डिक्रीज हो गया, फिर गायब हो गया, हमारा CO2 बॉडी से आ ही नहीं रहा, फ्लैट जो पार्ट है ना थोड़ा सा, फिर एकदम से बहुत सारा आ गया। तो देयर इज एपनिया और आइदर द पेशेंट इज डीपली सेडेटेड। So these are the few capnograms. We can diagnose many things just by looking at the waveform of the capnogram. Next important component of using any machine is setting up alarms. Alarms होते हैं हमारे मॉनिटर में जो कई बार अननेसेसरी भी बज रहे होते हैं हमारे पूरे ICU में। तो अलार्म्स दो तरह के हैं, विजुअल अलार्म्स एंड देयर इज दिस ऑडियो अलार्म्स। ऑडियो तरह तरह की साउंड है, विजुअल देयर इज ब्लिंकिंग, ग्रीन लाइट आएगी, फिर ऑरेंज और रेड लाइट डिपिक्शन होते हैं। तो कभी भी किसी भी पेशेंट में जब भी आप मॉनिटर अटैच करेंगे, सबसे पहले उसके जो वो है नॉर्मल हार्ट रेट है, नॉर्मल रेस्पिरेटरी रेट है, नॉर्मल BP है, तो आपको वैल्यू एक्चुअली सेट कर देनी चाहिए हमारे उसमें मल्टीपैरा मॉनिटर में, विच इज ऑल्सो वेरी इंपॉर्टेंट पार्ट ऑफ मॉनिटरिंग। अननेसेसरी आपकी जो नॉइज पोल्यूशन भी नहीं होना चाहिए, विच कैन बी डिटरमिनेंटल टू सिक पेशेंट्स। और ये है फॉर द सैचुरेशन वी शुड कीप द वैल्यूज बिटवीन 90 to 95 in newborns and 92 in children, and we can set alarms for arrhythmias also. Next important part is maintenance of the machine. Is extension cable should always be tucked in a bag when not in use. जब भी आप यूज नहीं हो रहे हैं, कहीं ऐसा नहीं हो कि वो नीचे पड़ा है, साइड में पड़ा है, जो कि ये है। तो we should use disposable accessories as much as we can, and reusable accessories should be cleaned with a split swab in between. and accessory when not in use should be kept in a labeled boxes. सबसे ज्यादा जो sensitive part होता है, जो सबसे पहले wear and tear में जाता है, that is this probe जो हम body से attach करते हैं, वो सबसे पहले खराब होता है. तो when we are not using any when it is not attached to any patient, ideally the probe should be cleaned with sprit and swab and should be placed in a airtight container. तो उसे हमेशा रख देना चाहिए airtight container में label box के साथ. Unnecessary इधर उधर बेड पे नहीं रहना चाहिए जब वो मशीन यूज नहीं हो रही है. So the key messages are real-time monitoring of all parameters is very important, and we should use sensors properly. We should always set age-appropriate alarms of vital important parameters, and early warning of adverse changes or trends should be taken care of, and response to therapeutic intervention should be done, and we should reflect proper functioning of other equipment too. These are the references for further studies, for detailed studies. And skills to be learned are to understand various parameters, identify compatible and appropriate sensors, identify and interpret abnormalities, and to set alarm limits. This is my last slide and the most important one and my favorite one. What is the most important monitor? सबसे main important monitor क्या होना चाहिए? Clinician. हम लोग जो हैं. We should always remain vigilant, integrate monitor information into patient care. कई बार वैल्यूज गलत आ रही होती हैं, आपका क्लिनिकल सेंस कुछ और बोल रहा होता है, तो वी शुड ऑलवेज गो विथ आवर क्लिनिकल सेंस रादर ब्लाइंडली फॉलोइंग द नंबर्स ऑफ द मल्टीपैरा मॉनिटर. My sincere thanks to all the contributors, and my special thanks to Dr. Chandrakanta and Dr. Shelly Avasti ma'am, and my thanks to all the panelists. And I also thank all the attendees who heard me throughout the session. Thank you.
Thank you very much, Dr. Anupma. Very good session.
Thank you, ma'am.
Very simple was made by you. I think this is the
Thank you,
most
ma'am.
commonly used thing which we have to always use, and we have to depend on the management on the multi-para monitor. On the management, this is the most likely the non-invasive methods are mostly used. One of the
Yes.
questions being asked here is EtCO2 as a surrogate marker of PaCO2 reading conversion factor. I don't know what the question exactly is, but can you understand what is the question?
Ma'am, I can't get the question actually.
So I think EtCO2 is a non-invasive method to get the, yes, it is a surrogate marker of PaCO2 level. And since PaCO2 we determine by ABG, and EtCO2 we get on a monitor. So this is a non-invasive method, and yes, obviously it is a surrogate marker. If we are not able to do ABG repeatedly, we can see these EtCO2 values on the monitor screen.
Second question is, ma'am, does EtCO2 relate with the PaCO2? Obviously, it relates with PaCO2. About
is there any conversion factor? I don't.
Ma'am, I'm not confirmed about it. I have to see.
I think the values are same. Even the PaCO2 level values are also 45, and EtCO2 is also 45. So values are same. So there is no. As far as I know, there is.
So capnography is EtCO2 or PaCO2. Capnography is a visual representation actually. Without as the ma'am said, graphic representation. What the ma'am says is it is a non-invasive monitoring, and PaCO2 is an invasive monitoring.
PaCO2 we get in ABG, and
yes, ma'am.
EtCO2 we get on a monitor. So if we are not able to do PaCO2 repeatedly, we can have a continuous monitoring of carbon dioxide, how much EtCO2 is there on the monitor. So the simple way, and most of the multi-para monitor which we will be getting in COVID management, I think will be having the EtCO2 sensors in that.
Sensors and.
I think this much is the.
No other question is there, ma'am.
No other question is there. Now we will proceed to the next session. The next session will be taken by Dr. R.K. Thapar sir from Sharda Hospital.
Madam, she has to show some videos, I believe. No.
Dr. Anupma? Dr. Anupma, are you there?
Yes, ma'am, I have to show 3 videos, ma'am. Sure, always remind me, ma'am. Thank you,
Okay.
sir. Thank you, sir. Okay, ma'am.
Okay, please kindly
Okay,
show
ma'am.
the
There
videos.
are 3 small videos, ma'am.
Yes.
Um, First video is about this BP monitoring.
For the blood pressure monitoring of patient, we have this non-invasive blood pressure monitoring NIBP cable with the one end attached to the module, and the second end will attach to the disposable BP cuff. And BP cuff is available in the different size depending on the baby's age and the weight. After connecting the cable and cuff to the baby, we will start measuring of blood pressure by pressing the knob or the touching the screen. That option is available in the monitor. And frequency of measurement of blood pressure is can be manually, or it can be set in the according to the requirement, from varying from 5 minutes to every 2 hours, that automatically the monitor will assess the blood pressure. While the measurement of the blood pressure, the reading will be there, and ultimately at the end the blood pressure with systolic, diastolic and mean will appear on the monitor. In this baby, the blood pressure in the higher range, so alarm is blinking. For the alarm setter, we touch the parameter and the separate window will pop up, and according to the gestation of and age of the patient, we can decide the low and high for each systolic, diastolic and mean blood pressure.
Second video is about the ECG.
ECG cable has also two part. One is the connecting cable, and second part that is connected to the cable and the ECG leads that have to directly attach to the baby. Usually we go for the 3 lead ECG with the left part, right part and the lower limb component that has to be attached. We can also attach to the lower left abdomen of the baby. Leads has to be attached to the baby with the electronic pads. After connecting the lead to the baby and to the monitor, there is a direct display of the ECG on the display monitor, and we can directly assess the pattern of the ECG of the baby, involving the assessment of the any electrolyte imbalance or arrhythmia. ECG leads also give a heart rate of the baby, and in the setup we can select lower limit or upper limit of the heart rate according to the age of the baby and directly involvement and assessment of baby. Thank you.
The last video is about the ETCO2.
For the end tidal CO2 monitoring, we have a separate micro stream sampling line that take the sample from the exhaled air and send it to the sensor that present in the separate module. In this version 19, we have a separate module that put into the satellite unit, and the sensor is present in this module. After inserting this module into the satellite unit, we have to plug in the microstream sampling line with one end to the module and other end connected to the baby, depending upon the baby on the invasive or non-invasive mode of ventilation. For the invasive mode of ventilation, we have a hub with connector to the ET and other end to the ventilator circuit. For the non-invasive mode of ventilation, we have a nasal cannula microstream sampling line that can be used for the baby. After connecting the sampling line, ETCO2 number will display on the monitor, and then we can regulate the baby's ventilation status by assessing the end tidal CO2 more frequently with the non-invasively, and ultimately that will increase the frequency of ABG and decrease the sampling of the baby.
Thank you, sir, Thapar sir, for reminding me again and again about the videos, sir.
No, you are most welcome.
Now I request Dr. Thapa sir for his session on modes of ventilation. I think, sir, there were questions for you before also. I hope that all the answers will be answered by you very nicely.
Okay. So you must have already covered it many of things. Anyhow, thanks Dr. Manisha for sharing the session and week after week. So hope it is making some difference to the participants. Let me share my screen. Is my screen visible, ma'am?
Yes, sir. Yes, sir.
Okay, great. I just
Sir.
make it full screen
Light
and
show. Yes.
Okay.
Yes, sir. It's visible.
Okay. So, dear friends, we'll move ahead since you have already taken a plunge in the swimming pool. So let's move ahead from mild to moderate cases to now we are dealing some related to some severe cases. So we have already learned about the mild, moderate, oxygen therapy, non-invasive ventilation. But today's day is for learning about some indications and about mechanical ventilation. You already have learned about the basic terminologies and how to monitor. So now we'll move ahead and I'll be talking about indications and modes of ventilation in a very simply form, in a simple form. So this is my learning objective, that at the end of session we should know what are the indications of ventilation, then what are the causes of respiratory failure as a whole, and trying to understand the various modes of ventilation and how to choose the appropriate mode. Okay, so basically today we'll be discussing about the basic things. We'll not go into the very advanced modes, which are hybrid modes. So let's see what is the normal respiration does to us, to a human being. The two main functions, getting inside the O2 from the environment or from the assist devices, and getting rid of the CO2, which is a product of our metabolism. So these are the main two functions of the lungs. And in case of any issues in these two functions, just remember basic things, that if there's a problem in oxygenation, which we can check from the SpO2, everybody is now having the SpO2 monitors at home also. And secondly, by doing ABG, that we get to know about the partial pressures of oxygen. And secondly, if there's a problem of carbon dioxide retention, that body is not able to get rid of the excessive carbon dioxide, which may be detected by EtCO2 or in the invasive method. So in case these two functions are not done properly, we can label it as respiratory failure. Now, before going ahead, let's revise. I again say that most of you must already be knowing all these things. This must be just a refreshing of the knowledge. So what are the causes of respiratory failure? The problem can be in the brain, that is the respiratory center, which may be hit by some poisoning or brain injury. Then the problem may be the message from the center comes through the spinal cord, which may get damaged, may be inflamed. Then the nerves, peripheral nerves, where we get the message through to the muscles, they may get involved. For example, in polyneuropathy, in GB syndrome. So again, there we already know that in these babies, there can be a respiratory failure. The problem may be in the junction, for example, myasthenia gravis, or there are some toxins which get attached to those neuromuscular junctions. Then the problem may be in the muscles itself, the myopathies, and the problem in the alveoli, that in the airway, which we less commonly see nowadays because of better management and better guidelines of asthma management. And the present issue, the COVID problem affects the alveoli, which may be in the form of pneumonias or ARDS or leading to pulmonary hemorrhage. So this is the issue which is bothering now as far as COVID is concerned. And for the ARDS and shock and other things, you will have a session tomorrow. So we'll restrict to today to the indications only. And then the problem may be in the cavity itself. I mean the pneumothorax, or there may be fluid accumulation. The lung is not getting expanded. So all these are the possible causes of respiratory failure. But as far as COVID is concerned, the problem is in the alveoli. There's a mismatch in the ventilation and perfusion because of the virus. Now, since we know the causes now, let's revise how we'll diagnose respiratory failure. So probably there may be some clinical criteria, there may be some investigations. So in the clinically, what we find is that the patient may be tachypnic initially, and subsequently he is panting for breath, and there's a lot of use of accessory muscles. He's putting himself into a position where he can use the accessory muscles of respiration. There may be some retractions which we commonly see in children. Then the patient may have bluish discoloration in the form of cyanosis. Initially, the cardiovascular system responds by tachycardia or hypertension, but subsequently, as the fatigue sets in, as the lactic acidosis, the anaerobic metabolism starts, so these things also fail. And similarly, you may hear some adventitious sounds. Whereas objectively, we can monitor the SpO2, and another better will be that if you can get a PO2 and PCO2 levels less than 60 or more than 50, that will justify the diagnosis of respiratory failure. And by that time, we have moved from mild to moderate to severe condition. X-ray test must have been shown, they must have been done, or maybe CT would have been ordered by that time, which will further reveal the changes of the disease condition. Basically, what we mean is that there's a lot of work of breathing. The patient, the body physiologically tries to improve upon the oxygenation by doing all the methods, but subsequently, even that also fails. That is how we get into respiratory failure. Now, as you have gone through the first and second day, you have learned about the oxygen therapy. So if there's only hypoxia, only SpO2 levels are a little on the lower side, but the patient is comfortable, patient is able to take his breath. In that situation, probably we can have oxygen therapy, maybe in the form of nasal prongs, mask, non-invasive sort of a thing, or non-rebreathing mask. So these are the modalities which you already have learned, or you know, and you are practicing all those things. And next situation will be that there is a hypoxia, but now carbon dioxide is also getting accumulated. But luckily, the patient has got good effort so far. So in that situation, probably we may get away with NIV. So decision has to be a clinician decision that at what level of hypoxia and hypercarbia you have to respond. So non-invasive, like CPAP, the BiPAPs, or maybe heated, humidified, high-frequency nasal cannulas. They also come in the oxygen therapy on NIV sort of a thing. But now the things have worsened further. Now the patient has got hypoxia, hypercarbia, and now the fatigue has set in. Even there is a lot of acidosis and anaerobic metabolism. Now the poor respiratory efforts are there. This is the time that we have to take a call. Now is the time to intubate. There is a separate session for intubation and extubation, which will be followed by after the lunch. So simple goals of mechanical ventilation will be that our aim is that we have to improve the oxygenation and ventilation. That means carbon dioxide elimination. But we have to do in a very, very optimal levels, not at the cost of cardiovascular instability. So let's see how we do it. So we have to monitor the oxygenation, which can be determined by the MAP, that is mean alveolar pressure, which is further determined by your PIP, that is the inspiratory pressure, the PEEP, that is the end expiratory pressure, the TI, where that is the inspiratory time, and your expiratory time. So there are 4 or 5 variables which determine the MAP. Manisha Madam must have already talked to you about these things. And the other component is your FiO2. Let me tell you that as far as these 2 parameters are concerned, both can be problematic, especially in the smaller kids, because oxygen has got its own problems and the increased pressure can be barotraumatic. So we have to choose the best of the parameters. Similarly, ventilation is determined by the minute ventilation, which is a product of a respiratory rate and tidal volume. So we have got limited things to control for these two to achieve our goal of mechanical ventilation. So let's see what are the various modes of ventilation. The modes of ventilation can be a controlled, mandatory ventilation. Everything is done by the ventilation, or we are assisting some of the breaths and rest of the breaths are controlled, that is assist controlled. or a further improvement that we are synchronizing, the machine is synchronizing the ventilation with the patient's effort, and we are trying to give synchronized intermittent mandatory ventilation. So here the patient is also getting some chance to have some autonomy sort of a thing. Then another improvement is pressure support ventilation. That means either we can use the pressure support ventilation as standalone, but or as a combination with synchronized intermittent mandatory ventilation. We'll see in the further slides. Broadly speaking, the ventilators function on two main things. Either you use a pressure mode or you use a volume control ventilation. That means you either target the pressure, the positive inspiratory pressure, and thereby getting to the desired tidal volume, may not be exact tidal volume, or we set the volume, that we set the tidal volume, but in that situation, we may or may not get the desired or the optimal PIP. So these are the two caveats in these two modes of ventilation. Let's see further. So this is how a ventilator looks like if we see from the anatomical perspective. Blender, you already must have known by this time that there is a system where it combines the oxygen and the air depending upon whatever FiO2 you set in. If you set in high FiO2, 60%, so it will similarly draw more oxygen and less air. So that it gives the oxygen cell, determines the FiO2 and it delivers that amount. Similarly, it will have inspiratory volumes, valves, which will decide your PIPs, and there will be flow transducers, which will be used by the triggers. And then at the expiratory end, there will be expiratory valve, which will take care of your PEEP. And similarly, there will be flow and pressure transducers, which will help us in optimizing the ventilation. So this is how a basic structure of a ventilation is. Now let's come to CMV mode. Now in the CMV mode, what happens is that here, as the name suggests, we are controlling all the breaths. Controlled mandatory ventilation. So that means we are not giving any chance for the patient to breathe, and patient has to be in that setting, in that situation, or we have to induce so much of sedation and paralysis so that we just take full control of his ventilation. Okay, and so there will be a pressure, this will be expiration. This is how the flow will be. There will be some inspiratory pause and then followed by expiratory pause. So the features will be that all parameters are controlled by the ventilator. Patient has got no autonomy to trigger the ventilator. But it can be useful only in the apneic patient. No? You know, if the patient has got the breath, so it will not be synchronized. The patient will have inspiration. The ventilator may be in the expiration mode. So there is a lot of asynchrony if the patient has spontaneous breathing. And if you have to have full control, then you have to have a heavy sedation and muscle paralysis. All these things, they come at a price. They are not, everything is not safe, but in a critical situation, we may have to use these modalities of treatment, but better things are available. That is assisted controlled ventilation. Now here, able to trigger. The patient is able to trigger, which may be in the form of a flow or a pressure, negative reflection. And the time trigger is with the ventilator. Okay. So rest of the things are again controlled by the ventilator. So the ventilator checks that the patient has started breathing. It tries to synchronize with that breath, apart from giving the set mandatory breaths. So this is another little better than your CMV mode. So here the patient can trigger the ventilator. Once triggered, the other parameters are controlled. Whatever pressures and whatever PIP, whatever TI you have set, that will be controlled by the ventilator only. So in this situation, there is a possibility of hyperventilation, because if the ventilator keeps on triggering at a regular intervals, if the patient has made some little effort, so it will be a hyperventilation situation, and there is a scope of asynchrony between various phases of the respiratory cycles. So little better than CMV, but still there is a issue of hyperventilation. Maybe we may have to use some amount of sedation here also. Now, what comes in the synchronized intermittent ventilation? Here, there is a slots. So the one will be the triggered ventilation will be a mandatory ventilation, that whatever number we have done, 20, 30, whatever we have said. In between the slot between two mandatory ventilation, the ventilator will not bother, will not disturb the spontaneous breath. So there is a beauty of synchronized intermittent mandatory ventilation. This is much better than the other two modes. Patient is free to breathe during expiratory pause. So that is the importance, that the ventilator will not deliver any breath in this period. So there are slots available. Whatever the rate you have set, only on those rates the ventilator will be functional, depending on the triggering. And in between those cycles, the ventilator will not deliver any breath. It will be patient's spontaneous efforts. Okay. So the advantages we can say that patient can breathe spontaneously between the mechanical breaths if he's in that clinical situation. If he's not in that clinical situation, then we'll prefer assist control. There is no doubt on that. It all depends on your clinicians and patient's work of breathing. And the ventilator support is tailored to the patient's demand. How much is the patient's requirement, clinical condition? Now, basically, it has come as a winning mode. When the patient starts improving after 2 or 3 days of the situation, and you have started the right treatment, and the pathophysiology is also settling down, in that situation, there is a possibility that we may decrease the mandatory breaths and let the patient breathe. So that way, we are encouraging the breaths, but definitely it will be in a little stage where the patient is not totally tired down. So it will reduce the need for sedation because we are allowing the patient to breathe, and it will preserve the spontaneous respiration by preventing the respiratory muscle atrophy. Because if we totally take control of the ventilation for a long period, then it is very difficult to extubate such babies. Patients become ventilator dependent. So, but the only disadvantage is that there may be, if we have taken an early decision to start on SMV, then probably the patient has not improved clinically, then there may be some increased work of breathing during spontaneous, maybe some amount of expiratory synchrony in between. There may be there if we have set the rate very not optimal rates are set. So this is the only disadvantage, but otherwise it's a good mode depending on the patient's condition. Now, added to that, there's another mode that we call it as a pressure support ventilation. This is another basic mode. In this, the inspiratory pressure support is applied to the spontaneous breath to eliminate. Now, we talked about the work of breathing to the spontaneous breath. Now, this is a spontaneous breath. So, now with the SMV, if we add pressure support, PSV here, so that whatever effort patient is doing, we just augment those efforts in synchronization. So that is how the pressure support will relieve the work of breathing in spontaneous breaths of SMV. This is the advantage of pressure support. This is a good thing about the pressure support ventilation, is that it helps to relieve work of breathing. Now, it may be used as an independent mode if the patient has got spontaneous breaths. We just want to augment. Patient has not fatigued so far. Patient initiates a breath, efforts exceeds the trigger sensitivity. Now, again, I will just dwell a minute. A trigger sensitivity, you have already been taught that there are 3 types: time, flow, and pressure. So there's a button there, knob there for the trigger sensitivity, which you can set either the pressure or the flow. That means either it picks up the ventilator, if the patient generates about 2 or 3 centimeters of pressure, it will pick up those. So depending on how much sensitivity you set, if you may set it at 5 centimeters, that means if the patient is able to generate negative 5 centimeters of pressure, then only the ventilator will augment that. So that means you are setting a very, very large pressure for the patient to develop. Or otherwise, if you set a very high sensitivity, -1 centimeter deflection, the ventilator will give. So you are keeping it very high sensitive. So depending upon the clinical condition, one can set the sensitivity between 2 to 3, and similarly flow can be set depending on the minute ventilation. So you have to tidal volume, you have to know the tidal volume, that if you can't set a tidal volume of 2 liters for a baby of 3 kg, because you know that if the rate is 60, tidal volume is about 6 to 8. If you take it 8, so it should be around 500 ml. It will not, patient will not be able to generate 2 liters. So that you have to see on your system, whatever ventilators you are having, that how it works. But there are two types, flow and pressure. Okay. Now, inspiratory flow is delivered to attain the target. So it will deliver the flow so that till the time you achieve your pressure level. And inspiratory flow will continue to maintain the target PS level as long as the patient is effort continues. So that's the beauty of pressure. So it is aligning with the patient's effort so that there is less amount of asynchrony. So it is one of the good modes of patient-triggered ventilation. That means we are giving autonomy to the patient. So in the initial stages, definitely we have to go for assist control or the control. Better is assist control. Subsequently, as the things improve, switch over to SIMV and give a pressure support so that we are able to extubate the patient properly. So this is how a pressure support ventilation will look like, that the pressure will be given. All breaths will be initiated by the patient. There will be trigger, patient will initiate the breath apart from the mandatory breaths. Once initiated, the ventilator will support the inspiration to a prefix level, whatever level you have set, maybe 10, 12, 14, whatever pressure level, it will deliver that much pressure. And beautifully, the pressure will be only till the time patient is in the inspiratory phase. If the patient gets into expiratory phase, the pressure support will stop. So that's the advantage of pressure support ventilation along with SIMV mode. So you have to set the trigger, as I told you. You have to set the pressure support, and maybe some ventilators may ask you that how you want to give the pressure support slope, a gentle slope or a vertical slope. And probably you have to set other parameters like PEEP, FIR2, as in other modes for the SIMV modes as you set in. So those things have to be set for the pressure support ventilation. So advantages are, a lot of advantages, that it preserves patient's spontaneous effort. The patient has got a control on all phases of respiratory cycle. It relieves the work of breathing in proportion to the level of whatever support you are trying to give, depending on the clinical condition, so that there is adequate chest size and you achieve the target SpO2s and the PO2s. Disadvantage is that patient has to breathe spontaneously for the efforts. Patient has to have some efforts. It can't be that patient is, you are totally giving too much of sedation and paralysis, then probably this will not work. The other thing is that variable tidal volume and minute ventilation with varying lung mechanics and patient's effort. So that we have to understand that in a acute stage, when the things are bad, when the pathophysiology is at the peak, in that stage, probably we may not be able to achieve, we may be able to achieve the pressure which we have set in the pressure control or the tidal volume in the volume control. But we may not be able to achieve the desired minute ventilation or the tidal volume in a pressure mode. Similarly, we may not be able to achieve the PIPs. PIPs may go up and low depending on the lungs compliance and resistance. So there is a trade-off between two modes of ventilation, either pressure or volume control. And the better modes are that where they try to hybrid these two things, that pressure regulated, volume control, volume guarantee. In a pressure mode, they are assuring you that this much volume is guaranteed. So those are the hybrid modes. They are the new modes which are coming in vogue, and many of you may be working with those ventilators. I don't deny that, and but we are sticking to the basic modes, and this is what we have to offer to you. Now, regarding the controlled modes, So we have got two options. Either we use the pressure or we use the volume control. So what is the problem in those things? So in a pressure control, we set a pressure. Ventilation delivers inspiration at a set pressure level. Whatever PIP you have set, whatever PEEP you have set, whatever the time you have set, and so it will deliver, and the IE ratio. Of course, the FiO2, whatever, depending on the patient's condition. Here, you have set the pressure, but we are not sure about the tidal volume. We may try to achieve the near normal, but it may not be near normal. We can't achieve the target volumes. We may be near normal. So that one has to remember that tidal volume will be variable and will be determined by the lung mechanics. So this is a pressure controlled ventilation. The advantage is that we know that pressure is a dangerous as FiO2 oxygen is for the lungs. That is a barotrauma. We already know that it causes. So once we know, if we put the limits that this much pressure is required for this condition, so we can set those pressures to non-barotraumatic levels. And of course, the pressure will help us in recruitment of the alveoli. There's the advantage of the pressure controlled ventilation, but tidal volume, we may not be able to achieve the target. There will be variable. If there's a things are improving, then tidal volume will be getting to the near normal. The only thing is that pressure may have, the high mean airway pressure may have some of the hemodynamic dysfunction, which we all of us know that if we keep high PEEP, which will result in decreased venous return and thereby decreased cardiac output. So we have to have a trade-off between these two things. So this is how a ventilation control, a volume control ventilation will look like. The ventilator will deliver a pressure to achieve. Now here, the ventilator, whatever set tidal volume you have set, depending upon 6 to 8 ml per kg, 20 kg baby, you have set at that I will try to achieve 160 ml of tidal volume. So the ventilator will give that much tidal volume, but the pressure may vary from breath to breath because of the lung mechanics. So this is the only difference between these two modes of pressure and volume control. The flow will be a stable inspiratory flow, which will be in the form of a square waveform. The controlled tidal volume will remain unchanged irrespective of the lung compliance because we have set the volume, but the pressure will vary. The pressure will vary. Okay. So advantage is that volume, you are giving adequate volume. So naturally it reduces the work of breathing, allows the patient to increase the minute ventilation. It can't decrease below the set tidal volume. We are assuring a minimum tidal volume is assured. So there is an advantage. But it may have adverse hemodynamic effects or inappropriate hyperventilation. Airway pressure will change, as I explained to you earlier, depending on the change in the lung compliance. And as the situation improves, the patient may have, because we are giving fixed flow, the high inflow demands from the patient may not be met. So patient will become ventilator dependent. That's one of the drawbacks of volume controlled ventilation. Okay. This is how the pulmonary graphics will look like whenever you see on your panel of the ventilators, that in the volume cycle, the airway pressure will rise like this, the alveolar pressure will follow suit, and the flow will be a square waveform. Whereas in case of pressure cycle, the airway pressure will be that inspiratory pressure, then it will remain plateau for some time, and then the expiration. However, the alveolar pressures will have a gentle slope. Okay. Similarly, this is how the flow will be, that immediately it will fill up and then the expiration will start. So this is how both the things will differ. So the key message is that synchronized and patient triggered ventilation, that means pressure support ventilation, they are preferred. Sick children, please go ahead with assist control. Mild to moderate illness, come back to SIMV. The other thing is that you may be using depending upon your skills and the friendliness with the machine. So try to use that mode in a sick child in which you are confident. That is more important. And do try to monitor the delivered parameters, as my previous speaker has also mentioned. Lot many things are available on the ventilator panels. You have to just rotate the knob and go to those parameters. You may find compliance, you may find constant, time constant, you may find tidal volume, inspiratory tidal volume, expiratory tidal volume, dynamic resistance, dynamic compliance. So many things one can learn once you get friendly with your machine. And of course, you should set the alarms, audio-visual alarms, which tells you, which cautions you that something is wrong. There may be high pressures, there may be oxygen loss, there may be air loss. So they will keep on blinking you with amber colored, and then there's some of the alarms may be a serious alarm that they give you red color alarms, and the change in the volume of the audio alarm also. So please listen to them. Don't just try to switch off. Attend to those alarms, and if in case you are able to sort it out, please sort them out. Lot of things are available for improving our skill and knowledge about the ventilation. These are the various things which are available, and basic aim is that one should have a little idea about the types of mode, which is not very difficult. Choosing a mode, I think, is easier now, and set the parameters depending on the patient's conditions, which will be further highlighted in the subsequent talk after the lunch, how to set various parameters. And you must analyze the displayed parameters, that you have set the pressures, how much pressure it is actually delivering, how much volume it is delivering. And the most important is that try to have the machine and patient synchronization. That is very important, because if both are working against each other, that will create problems for the patient in the form of barotrauma. So that we don't want. We already have a sick child. We want to improve, help that child to optimize his oxygenation. So look for the synchronization. Lot of people have worked for this module. Thanks to all of them. Thanks to the chairperson, Dr. Manisha. Every week they are there. And we hope that you get some benefit out of these talks. Though practically it is your own unit where you have to work and learn the hands-on things. With this, I complete. If there are questions, I will be able to
Yes,
answer
sir.
them. Surely.
Yes, sir, there are questions. So
Sure.
one question, if the child is on PCV, retains carbon dioxide, should we switch over to volume control mode?
First, you have to see cause of CO2 retention, whether there is a tube block, either you are giving the bias flow is adequate or not. So if you think, yes, you have looked after the mechanical causes of raised in CO2, if you can sort out those issues, probably things will, or maybe you can increase the rate. If your rate is not adequate, then you can increase the rate. So if you do all these measures, and if the things still not work, then probably one can choose the volume control. But listen, think to the issues, tube block, and then maybe your IE ratio, the respiratory rate. So these are the issues one can look for if there is a problem of CO2 retention.
Yes, of course, sir. I think we can first manipulate the respiratory rate and IE ratio, and then if even then it's carbon dioxide still retention, we can go over to volume. But try to switch to one mode, I think.
Yeah.
So second question is, which is preferable in infants and children? Pressure control or volume control?
We have been using pressure control, so we are comfortable, but nowadays volume controls are there. So that younger generation is more comfortable with the volume control. So it is again your own choice. Not much to choose between. Whatever modes you are comfortable, you set those timings. So personal choice is there, and the more skilled or more adept you are in that machine, more important.
Yes, sir. The second, one more question. Can we manipulate minute volume in PCV?
That you can be, that's what I was saying, that you must check the, you may not be able to achieve the exact volume.
That is the disadvantage.
But you may be able to nearby only. You may not be able to reach 160, but ठीक है, 130, 140, that's sort of thing. As the situation will improve, the minute ventilation will definitely improve. It will improve. But targeting that, maybe that in that situation, if you're targeting, I have to reach this much, then probably you may be ending up giving more pressures, which may be harmful. So that we don't desire. That already in a sick child, we have to use the parameter, we have to use those settings where we don't do much harm to the child already. We just have to optimize his saturation and CO2.
Yes, sir. One more question is there. Is PSV plus PEEP somewhat similar to BiPAP?
Yes, maybe, but BiPAP we set two parameters, two PEEPs, one and the one lower and one high, and spontaneous breathing looks BiPAP.
I think, sir, they are similar.
They are
but
similar.
PSV is invasive.
Yeah, that's what I was coming to. That in case of you have intubated, then probably it will be other way around. Otherwise, BiPAP we can give with the non-invasive also. That we can give with the non-invasive also.
BiPAP is usually non-invasive, and PSV we usually use in a weaning mode, as a weaning mode in invasive ventilation.
And then we can top it up after extubation. We can top it up with the BiPAP or CPAP. That's sort of a thing. Right?
So which is easy to be skilled, PCV or VCV for us who are going through it for the first time?
Anything, Manisha? Anything you want to say?
I think there is no much difference between PCV and VCV. It's basically pressure control and volume control. Both are similar. Earlier, we used to use, as sir told, that in most of the children, we use pressure control mode only. But nowadays, it is recommended as far as possible, in which you are more comfortable, as most of the people may have used volume control in adults. I think in COVID era, most of the people have done the adult duty, the pediatrician, even we have mixed participants here. So if you are well versed with volume control in adults, you can, I think, go in children also.
But just restrict to the tidal volume, which is recommended. Don't go for the high tidal volume.
According to the age.
Just restrict to the 6 to 8 ml per kg, and just have a look on the pressures also. That how much pressures you are able to generate with those volumes. So that will be just advice. But volume control, you can go ahead if you are comfortable using it. No embargo on that. Surely.
The next question. From SIMV board, can we direct extubate the infant?
Yes, you can extubate. We can give a spontaneous breathing trial, SBT trial. We can give that trial. And once you are comfortable, off inotrope, off sedation, you have already stopped any agents if you have used, and then we can give a SBT, spontaneous breathing trial, for some time. And then patient is able to breathe, efforts are there, comfortable hai, there's no, patient is not getting distressed, no work of breathing. Surely you can do a proper suction and take proper measures. And maybe after extubation, maybe we give some, we ready with some nebulization, so that in case of prolonged intubation, probably there is an element of some glottic edema, subglottic edema. So be ready for that in case you have known that this, if there is a short ventilation, 48 to 72 hours, probably no, you don't need. But if it has been a long ventilation, probably in that situation, as we use steroids, peri extubation, we use steroids, and then at times we give adrenaline nebulization immediately after extubation, just to avoid the extubation failure. We don't want that. So in the next lecture, you will hear about the extubation. We don't want that once you have done your job and you are ready, you have checked the readiness for extubation, then the extubation should also be a planned affair, so that we don't fail, that we don't want to re-intubate, restart the process. That will not be good. So take your time for the extubation, get him ready for the weaning, and then surely one can, after giving SPT trial and taking due precautions of suction and asepsis, please go ahead with the, and maybe after extubation, if things are going all well, in neonatology we do get a X-ray chest so that to see that there is no any collapse or something like that. But otherwise, clinical monitoring is a must.
Yes, of course, sir. In lecture also you told, I think in SIMV while weaning we decrease the respiratory rate so that the spontaneous efforts, number of
Yeah.
spontaneous efforts increase and the number of mandatory breaths are gradually decreased so that the spontaneous efforts improve more and more with the time
Yeah.
being as the patient improves. So this is one of the weaning mode also.
Yeah,
Yes,
yeah,
obviously.
surely. But we have to be a little more,
Cautious.
one should always think that I don't need to re-intubate. But that should be
Yes,
our aim.
yes, of course.
That should be our aim.
Yes, I think this much was the question, and
Chalo.
most of
Thank
the
you.
earlier
Nice,
questions
nice
are
meeting you on the Zoom every time, and hope the participants do make some sense of it. And we are thankful to all of them for attending. Thank you very much.
Thank you, sir. We will have a 20 minutes break, and after that, at 2:20 sharp, we will be again coming, and the next lecture will be intubation, how to intubate. So, thank you very much, all of you. We will have a break for 20 minutes, and we will just start at 2:20 sharp.
Thank you. Thank you. All.
Dr. Chandrakanta ma'am.
Yes, Manisha, I'm here. Thank you.
Yes, ma'am. Now the session will be moderated by Chandrakanta ma'am.
Thank you, Manisha. And I hope the participants are coming back. I can see only 128. So should we wait for 2 minutes more? Or I think we can start. Otherwise, we get late after 4 p.m. So till now we have discussed about the basic terminology. Now we are aware about the basic terminology of invasive ventilation. What are the various modes of ventilation and how to monitor? So before actually starting ventilation, we need to intubate the child, and that Dr. Kavita from IMS BHU is going to tell us that how to do endotracheal intubation and how to manage airway in children. So welcome, Dr. Kavita.
Thank you, ma'am. Good afternoon to everyone. I'll start with my presentation. So in this presentation, we'll be discussing about endotracheal intubation in children. Our learning objectives will be understanding the key anatomical differences between pediatric and adult airway, comprehension of the equipment and preparation required for endotracheal intubation in children, procedural step of performing endotracheal intubation. We'll be discussing about indications, contraindications, anatomy, preparation, steps, aftercare, complications, and pitfalls that we face. Now, for the indication of endotracheal intubation, if there is a failure of oxygenation or ventilation, which can be stated as partial pressure of oxygen less than 60 millimeters of mercury on 60% FiO2, or if the partial pressure of carbon dioxide is more than 50 millimeters of mercury, or if there is any inability to maintain or protect the airway, or there is a severe systemic conditions like hypotensive shock, or patient require cardiopulmonary resuscitation, or we need to give anesthesia, or we need to do procedures which require sedation, or we need any neuromuscular disorder is there in patient, then all these are the indications for intubation. Now, contraindications, there is no absolute contraindication, but there are certain relative contraindications like anticipated difficult airway, patient is difficult to intubate, or patient requires alternative airway, or we are waiting for the expert team. So before discussing the procedure, we need to know about the relevant anatomy. So there are certain differences in the airway anatomy of adult and a pediatric patient. Like if you see the shape of the airway, then it is cylindrical in case of adult patient, or whereas in case of pediatric patient is funnel shape. Tongue is relatively small compared to the pediatric patient. In case of adult patient, in pediatric patient, tongue is large, so it occupies the area of the mouth, and epiglottis is shorter in case of adult patient, whereas epiglottis is longer. It is U-shaped and it is floppier in case of pediatric patients. So it is easily collapsible in case of pediatric patients, the epiglottis. If we talk about the narrowest part, then in case of adult patient, it is the vocal cord, whereas in case of pediatric patient, it is the cricoid ring, which is the narrowest. And if we talk about the overall position of the airway, then we'll see that in case of pediatric patient, naturally the airway is more anteriorly placed compared to the adult airway. So that makes our job a bit difficult compared to the adult airway. So what we need to do is first we need to achieve the airway alignment of the patient. As we can see in this slide, there are certain problems that we are facing, like relatively large head size in case of infants. There is a natural flexion of the neck because of the large head size, which is compressing the soft tissue. And tongue is relatively large, that we have already discussed. So tongue keep falling back, which can lead to airway obstruction. So that's why these are the reason we need to align the airway. And for the airway alignment, there are certain endpoints. Like if we see the Hello. If we see the glabella and chin plane, it should be horizontal to the surface. And if we see the neck part, it should be open and wide. And if we see the external auditory meatus of the patient, it should correspond to the sternal notch of the patient. So there should be in straight line with each other. And how this position can be achieved? First of all, place the child on the horizontal surface and see if these endpoints are achievable or not. Then we can start placing headrest, and then again we can check for the endpoints. And if still it is not there, then we can place the shoulder rolls below the shoulder of the patient, and then again we can check the endpoints, and we can see whether the airway alignment has been achieved or not. This is again showing this same slide, which is showing what we need to do. So here again, we need to aim for the airway alignment by achieving various endpoints that we have discussed. The position for endotracheal intubation is called sniffing position or the ear to sternal notch position. So in if we see in the other method, then we can see the ear of the patient and a line going through the anterior part of the shoulder. So this line should be horizontal to the surface. This line how this alignment can be achieved, so that this line is horizontal to the surface. In case of infant, by placing a shoulder roll, this alignment can be achieved. In case of small child, we might not need anything. In case of older child or adult patient, if we place a support below the head, then this line can be achieved parallel to the surface or parallel to the ground. So how this is how we obtain the sniffing position or the ear to sternal notch position. So we need to identify the structures. So these are the structures we are aiming for. This is the epiglottis, this is the vallecula, this is the vocal cord lining the glottic opening. These are the arytenoid cartilages, and this is the array epiglottic fold, and this is glottic opening. So these are the anatomical structures that we need to identify once we have done the laryngoscopy. So this is again the anatomical landmarks that are being shown. So this is the esophagus, and so we should have a clear cut idea, we should have a clear cut image regarding how does the glottic opening look like and how does the esophagus looks like. So when we see the glottic opening, it is always lined by the vocal cord, which are the two glistening white structures, which are easily identifiable once we lift the epiglottis of the patient. So we should have an idea about this structure and how it is different from the esophagus, so we don't make any mistake. So there are different shapes of the epiglottis, and the shape of epiglottis changes according to the age. So if it is newborn, it is inverted U shape. In a child, it is slightly triangular. In case of adult, it is semicircular, inverted. So this is how the shape changes with the age. So we have identified the structures. Now we need to do certain preparations before attempting for the procedure. And these preparations require suction apparatus, oxygen, airway, and personal protective equipments. In case of suction apparatus, it can be wall mounted or it can be standalone. Suction pressure should be 80 to 100 millimeters of mercury. Suction tube should be available, and suction catheters from the size 8 to 14. In case of oxygen, we can provide by non-rebreather mask, or we can provide by nasal cannula. We might need ambu bag with the reservoir, or we might need oxygen tubing. For the airway, we should have appropriate size endotracheal tubes and oral and nasal airway and laryngeal mask airway in case we need. And the personal protective equipment should be ready. Now, for the medications, we use pre-medications, we need paralytic medications, and then we can use, or we might require resuscitation medications like epinephrine, atropine, fluids, etc. In case of equipments, we need laryngoscope, size, appropriate size blade, appropriate size mask, ambu bags, stillets, IV lines, syringes, tape, towel pads for airway alignment, stethoscope, monitor, end tidal CO2, calorimetric capnograph, and ventilator. So this is the checklist of the equipments that we require before attempting for the procedure. So we should always check the equipments according to this list. If we talk about the laryngoscope, there are two type of laryngoscope that we need in pediatric patient. One is the Miller blade, and other one is the Macintosh blade. Miller blade, if we see, it is straighter and thinner, and it can be used in infant and young children. When we are using the Miller blade, then we need to lift the epiglottis directly, and it provides better control of the tongue compared to the Macintosh blade. If we talk about the Macintosh blade, then it is curved, it is wider. It can be used in older children and adults. When we are using the Macintosh blade, then we need to place the tip of the blade into the vallecula. We don't directly lift the epiglottis, but we place the tip into the vallecula and try to lift it. And this blade curves around the tongue. It engages the tongue and keeps the tongue away from our airway manipulation. There are different sizes available for laryngoscope. For preterm, we can use 0.0 to 0. For term unit, we can use 0 to 1. For infant, it is 1. For toddler, it is 1. For preschool children, 3 to 5 years of age, we can start using Macintosh blade, which is size 2. And for school children, 5 to 12 years, we can use Macintosh blade size 2 to 3. So from preschool to school, we can use Macintosh blade. Now we need to know which size of endotracheal tube which will fit into the airway opening of the patient. To know this, we can remember it by a formula, which is for uncuffed tube, it is Ag near by 4 plus 4. For cuffed tube, it is Ag near by 4 plus 3. Once we have calculated the definite size, then we should keep a size above and a size below to the size that we have calculated in case we might need it. And for the depth of insertion, we can again remember it by a formula, which is Ag near by 2 plus 12. Or we can roughly multiply the internal diameter, which provides the size of the tube, 2 into 3. So we can multiply the internal diameter by 3, and we can calculate the approximate depth of insertion into the patient. Cuff pressure, we always keep below 20 centimeter of water to avoid any kind of injury to the airway. These are the different sizes of the endotracheal tube which we may need into the pediatric patient. So tube size is determined according to the internal diameter of the tube. So these are the different sizes of the tube. And if we are using an uncuffed tube or if we are using a cuffed tube, then outer diameter corresponds according to the internal diameter which is mentioned. So it is different from the uncuffed and the cuffed tube which is mentioned in the slide. Intervention, we might need adjuvant equipments, stillet for endotracheal tubes. Like this is a hyperglutated glycoscope stillet, or we might need standard endotracheal tube stillet, or we might need elastic bougie. The other equipments that we require is ambu bag. For neonates, we need the size of the 200 to 300 ml. For infant and young children, we need 450 to 500 ml. For adolescents and older children, we need 1000 to 150 ml. Now we need to determine the size of the mask, and to determine the size of the mask, you don't have to remember it by number or by the size. We can just keep a mask on the airway of the patient slightly and we can see whether it is fitting or not. It should not be large to cover the eyes, or it should not be small enough as not to ventilate the patient. So we should always keep the triangular area of the mask on the nasal bridge and the circular area on the chin of the patient, and then we can see whether it is covering both part nicely or not. If it is covering, then it is the size of the mask that you require for mask ventilation of the patient. And then holding the mask of the patient, we use ENC technique. So this is the C technique, thumb and index finger. With this thumb and index finger, we press the mask on the airway of the patient. And this E and C technique, in this E, we keep the fingers on the bony prominences of the chin. And with this bony prominence, we try to upwardly lift the airway of the patient. So there is a upward and outward movement, which is called jaw thrust. So this is how we are doing two things at the same time. One, we are pressing the mask on the airway of the patient. With the other, we are doing slight upward and outward movement of the patient, giving jaw thrust to the patient. Again, this jaw thrust helps in alignment of the airway. So we should know how to properly give the jaw thrust to the patient. Then again, we can use the two hand technique. In this two hand technique, again, we are using the thumb of both the hands to press the mask slightly on the airway of the patient. And with the index finger, again, we are trying to move the mandible of the patient or lower jaw of the patient in the outward and in the upward direction. So these are the two techniques by which we can mask ventilate the patient. The other adjoint equipments that we require is the suction apparatus. So for a corresponding endotracheal diameter of the tube, we need the corresponding suction catheter size. So these are the sizes which are given. And that the thing that we have discussed, that we should keep the suction pressure between 80 to 120 millimeters of mercury, because if we are going above this, then we might cause mucosal injury to the pediatric patients. So we should avoid going above to this pressure. Then again, the other equipment that we might require is the oropharyngeal airway. This airway will protect the airway of the patient, and it will protect the tube biting as well. So we might need Goodell airway. The sizes of Goodell airway is from 00 to 4, and the length is approximately 4 to 20 centimeter in length. So how do we see whether the Goodell airway is of appropriate size or not? So we can always keep this upper part of the Goodell's airway at the midpoint of the incisors of the patient, and this lower or the distal part of the Goodell airway will correspond to the angle of the mandible. So this is the appropriate size. And while seeing the size of the Goodell airway, see the curvature, it should be in the upward direction. So this is how we can calculate the size, see the size, or we can just remember by the color. These are color coded for the easy memory. Again, the other adjoint equipments that we require is tape for securing the endotracheal tube, or the monitors to monitor the pulse oximetry of the patient, capnography of the patient, or we might need capnograph. So personal protective equipments, since we are in the COVID times and the pandemic times, so personal protection equipment is very important. So these are the personal protective equipments that should be kept ready before attempting for any kind of procedure. Pre-medication that we need are the tranquilizers, which can be benzodiazepine or promethazine, or we need opioids, which is fentanyl, morphine. Non-opioid, we have to use acetaminophen. Dissociative agent, we can use ketamine, anticholinergic agent, glycopyrrolate or atropine, or we might need antacids or H2 blockers like ranitidine or metoclopramide. So we are using midazolam, or if we are using ketamine for the patient, the routes can be IV or intramuscular. So doses for IV and intramuscular is different, and the onset of time is different. If we are giving intramuscular, then the time of onset will be delayed compared to the IV route. Again, for the ketamine, we can use the IV route or the IM route. So whichever is feasible for us, we can use. Any procedures, we might face complications. So we need to use drugs for resuscitation. So we should keep ready epinephrine loaded syringe in the dilution of 1:10,000, and we can give it by the 0.01 mg per kg IV. We might need atropine if we are facing the problem of bradycardia. So give it in the dose of 0.02 mg per kg. Fluids are required for the patient. We might need calcium gluconate and the hydrocortisone for the patient. In the COVID patient or in any full stomach patient or any trauma patient, these are the patient where we need rapid sequence intubation. So apart from the preparations that we have seen, and apart from the equipment that we have discussed, what we need to keep in mind that if we are going for rapid sequence intubation in a patient, then we should always check ventilate, because we should not take away the spontaneous breathing of the patient by giving neuromuscular agent if we are not able to mass ventilate the patient. So the first thing is you should always check ventilate the patient, and if you are sure that you are able to ventilate the patient, then only we should use the neuromuscular agents, because once neuromuscular agents are given without doing check ventilation, then we might land up into a very big complication of not uh, ventilating and not intubating the patient. So we should try avoiding this. Now, the drugs that we require for rapid sequence intubation are again the induction agents, which is etomidatate, propofol, ketamine, fentanyl, midazolam. For neuromuscular relaxation, we can use succinylcholine, which is a depolarizing relaxant, or we can use non-depolarizing muscle relaxants like rocuronium and vecuronium. The doses are mentioned here, and we should be aware of the complications that these drugs might cause. So we should know how to manage the complication without before using a certain drug that we want to use. So these are the drugs, and these are the doses, and these are the complications that we should always keep in mind. Now, for pre-oxygenation, you should always use 100% oxygen for 3 to 5 minutes, because it increases the safe apnea time of the patient. Apnea time where we won't be ventilating the patient, and we won't be oxygenating the patient. This is the time when we are doing the laryngoscopy and intubation of the patient. So, if patient is spontaneously breathing, try to use non-rebreather mask or the nasal cannulas. But if the patient is not spontaneously breathing, or the patient is in apnea or gasping or not breathing, in that case, use bag and mask ventilation. So step one, always try to achieve the proper position. Keep the patient on the surface. Give slight neck extension uh, uh, to open the airway and align the airway of the patient. Then hold the laryngoscope. So holding the laryngoscope depends upon the dominant and non-dominant hand of the doctor. So if you are try to hold the laryngoscope into the non-dominant hand, because with the dominant hand, manipulation of the airway is easy. So try holding the laryngoscope and try learning the technique by holding the laryngoscope into the non-dominant hand. So this is the proper hold of the laryngoscope. There are two techniques which have been described in the slide. So one, we hold it by the handle, giving full grip to the handle, and the precise control is not there. But to lift the airway, or to do the lifting in case of laryngoscopy, in case of adult patient, we need this, because we need more power to lift compared to the pediatric patient. So in adult patient, we can use this technique. Or in case of pediatric patient, the pediatric airway is very delicate. So we can try, we can hold the laryngoscope near the blade of the laryngoscope. It can provide easy manipulation for the airway. So these are the two techniques which have been described. But as far the technique is concerned, we should use the technique in which we are comfortable. And you generally need this technique in case of adult patient compared to the pediatric patients. So opening of the mouth, you can use the scissoring technique. So this is the scissoring technique where we are pushing the lower lip of the patient with the thumb, and with the fingers we are trying to open the upper part of the mouth of the patient. So this is the seasoning technique through which we can open the airway of the patient. Then introduction of the laryngoscope of the patient. We should always go from the angle of the mouth. We should not go from the middle of the mouth of the patient for laryngoscopy. So it is inserted along the right side of the mouth of the patient at a slight angle. And then we should, when we are introducing the laryngoscope, we should do gentle movements, and we should keep seeing what are the structures that we are seeing while doing the laryngoscopy of the patient. So this is again, the whole blade is advanced into the mouth of the patient, and we are generally opening the airway and trying to lifting the laryngoscope, visualizing the parts that we need to identify. Again, this is the wrong technique that have been shown in the slide. We are using the middle of the mouth to introduce the laryngoscope, which is wrong. You should always go by the sides, not from the middle. So that was the incorrect blade placement. So once we have positioned the patient, and once we have done the laryngoscopy of the patient, so this is the structure that we need to identify. So when we are advancing the blade into the mouth of the patient, giving the cricoid pressure and not giving the cricoid pressure again depends upon the personnel who are performing the procedure, because cricoid pressure might lead to distortion of the airway anatomy of the patient. So it makes visualization of the airway difficult compared to not giving the cricoid pressure. So it is again up to us whether we want to give the cricoid pressure or not, if there is any indication of giving the cricoid pressure or not. So again, this is the slide which is showing these are the structures where we need to identify. Once we have identified, place the tip of the blade into the vallecula if it is an older child. And while placing the tip of the blade into the vallecula, try lifting the laryngoscope and try lifting the epiglottis. So this is again the lifting of epiglottis. Once we are done with lifting the epiglottis, we'll be able to identify the structure, which is the glottic opening of the patient. And this is showing the negotiation of tube through the glottic opening. So this is where we need to negotiate our tube. Now, for correct placement, we can see clinically. So when we have to see clinically, see the bilateral chest rise of the patient with each ventilation. Auscultate the patient, equal entry should be there bilaterally, and auscultate the patient over the abdomen. Breath sound should not be audible at the abdomen. On the monitor, adequate oxygenation should be there. SpO2 should be more than 90%. And if we have the facility of capnograph, then we should be able to see the definite waveform of the capnograph or the color change. Or if we are using a chest X-ray, then our placement of the tube should be 3 centimeter above the carina. So these are the different methods where we can check the correct tube placement. This is the capnograph. This is the graph we need to achieve. This is the graph which will be visible on the monitor once we have done the correct placement. Again, X-ray, it should be above the carina, 3 centimeter. So we can use LMA also. Certain times we are not able to negotiate the tube, endotracheal tube. Then in those scenarios, we can use laryngeal mask airway. So this is the laryngeal mask airway. Again, choose the appropriate size of laryngeal mask airway and deflate the cuff of the laryngeal mask airway. And after deflating, lubricate this dorsal surface of the LMA. Use pen holding fashion to hold the laryngeal mask airway, and insert the laryngeal mask airway along the hard palate and roof of the mouth of the patient. So insert and advance further. And once you have achieved the placement of the laryngeal mask airway, then inflate the cuff of the LMA. There will be slight outward movement of the laryngeal mask airway. And for checking the placement, and again we can check clinically, attach the circuit and auscultate bilaterally whether the patient is being ventilated or not. For securing the endotracheal tube, we need dynaplast, we need micropore. These are the tapes which we need, through which we need to secure the endotracheal tube. So this is the method to secure the endotracheal tube. We can cut the slit the dynaplast, and then we can secure it around the tube and then place it on the mandible or the maxilla. And there are different techniques to secure the endotracheal tube. We can use any technique, but proper securing the endotracheal tube is very important. And it becomes more important when we are using a uncurved, which we might need to use in pediatric patient. We have to use very often in case of pediatric patients. So proper securing of endotracheal tube is very important. So this is how we secure the endotracheal tube of the patient. Again, this is showing the how we secure the endotracheal tube of the patient. Then we might face certain complications. We are doing the procedure, or once we have done the procedures, like hypoxemia or bradycardia, or we might face hypotension, hypertension. Patient may land up into laryngospasm, bronchospasm, or we can cause trauma to the mouth, larynx or vocal cord, or we can do esophageal intubation if we are not very expert, or we might lead to perforation to the patient, or there can be tracheal perforation, or there can be MSS leading to aspiration and cardiac arrest of the patient. So we might face acute deterioration in post intubation period. So we should always rule out certain conditions, and we can remember these conditions by dope. The first is displacement or misplacement of the endotracheal tube. Other is the obstruction of the endotracheal tube because of blood or secretions, or there might be pneumothorax to the patient, or there can be equipment failure or the ventilator failure. The common pitfalls that we face while doing the procedures is rocking movement of the laryngoscope. So we should avoid doing this. Or if there is an inability to visualize the glottic opening, sometimes we have not reached to the point we need to reach, or sometimes we have gone beyond the vocal cords, so we are not able to identify the vocal cords. So that's why when we are doing the laryngoscopy of the patient, we should not do in hurried manner. We should go slowly. We should keep identify the structures, and then we should complete our procedure. Or we might do right main strip endotracheal insertion. To avoid this, bilateral checking bilateral air entry is very important. Or we can take multiple attempts. Sometimes you are not able to intubate, then multiple attempts will lead to complications. So try to keep your attempts less than 3 within 20 to 30 seconds. So there can be equipment failure. To avoid this, we should always have a checklist. So before attempting for procedure, be it endotracheal intubation or there is any other procedure, we should always have a checklist. We should check the patient and we should check the equipments according to that checklist. Now, since we are talking about the COVID times, then what is the difference is we need to have personal protection equipment. This is the first and the foremost thing that we should follow. So first of all, we should be ready with the personal protective equipment. This should be the first one in your checklist. Then you should always call an experienced personnel to perform the procedure if we are not very confident, because we should not do repeated attempts in case of COVID patients, and we should avoid awake intubation in case of COVID patients because of the aerosol generation. And once we have achieved the intubation, inflate the cuff as soon as it possible before attempting for bag and mask ventilation. And we should not do open suction. Don't open the suction. Don't open the circuit of the patient and then do the suction of the patient. Always try to use inline suction catheters. These are the certain innovations which do help us in the pandemic scenario. So this is the video laryngoscope. This laryngoscope gives us a distance from the airway of the patient, and at the same time, it is make us easy for us to visualize the structures that we need to identify. Then some viral filters are also there to reduce the viral translocation. So these are the innovations. The take-home message for our presentation is pediatric intubation is an important skill in the management of critically ill children. So knowing the anatomy is very important. Appropriate equipment should be ready at all times in pediatric ICU and in crash cart. Medications are an important component. So proper medication, proper dosing is very important. Stepwise insertion technique should be performed for optimal success. Post-intubation care is essential part of intubation process, and complication should be anticipated early and they should be treated early. So this is my presentation.
Thank you, Dr. Kavita, for this excellent presentation.
Thank you, ma'am.
And I see no question related to your talk. I hope everything is clear to the participants. So thank you very much.
Okay, ma'am. Thank you, ma'am.
This child is now intubated and we need to ventilate the child. So Dr. Yashwant Kumar Rao is going to tell us that how to start ventilation, what should be the initial settings, and how we have to modify them. So I welcome Dr. Yashwant Kumar Rao. He is HOD of the Department of Pediatrics at GSVM Kanpur.
Thank you, ma'am. Now, is it visual, ma'am? Hello.
Not yet.
Is it visual?
No, not Dr. Yashwant. So now your screen is visible. Okay.
Yeah, ma'am. Okay, thank you, ma'am. Now I'm going to start. Actually, ma'am, my dresses are a little bit different. Today I was doing Shiv Puja, Rudra Abhishek. So today I'm not looking like doctor.
No issue.
Yeah, thank you, ma'am. So topic for today is invasive mechanical ventilation, initial setting and how to titrate. Half of my talk already has been covered by Thapar sir and Kavita ma'am because child has been intubated. My job is to ventilate the baby and titrate the setting according to the arterial blood gas and clinical parameter. So before my talk, we will discuss the case. So by case-based scenario is there. So this is the 10-year-old male OB child who coming to the emergency with history of fever for 5 days, myalgia for 5 days, RT-PCR was positive 5 days ago, and child was there, breathing difficulty and cough for 3 days. Like every time in second COVID wave, everybody knows that all the patients are coming in very low condition because they have arranged, somehow they have arranged cylinder at home, monitoring the pulse oximeter, BP, etc., etc. And when they deteriorate, they came to the hospital. So this patient, they also came in the deteriorated state, progressive worsening, and admitted to the hospital, put on NIV, non-invasive ventilation, BiPAP board पे इसको रखा गया था. Oxygen requirement gradually increased to maintain the SpO2 and FiO2 was 80% with support of 12/8. So quite high support with quite high FiO2 child was maintaining, but What is the clinical examination? Adult ICU is little bit different to the pediatric ICU. In pediatric patient, clinical examination is very, very important because all the organs are good, functioning normally. So any problem is there, it reflects to the child's face. Seeing the chehra of baby, seeing the vital of baby tells many things before the investigation. So with this setting, 12/8 BiPAP and FiO2 80, child was sleepy. This is very important. Sleepy means कि there is some sort of CO2 retention because COVID case is the pneumonia case and child is sleeping. CNS is normal, तो sleepy means CO2 retention. Appear tired, थका हुआ है, सांस लेने में प्रॉब्लम हो रही है. Heart rate is 135 per minute. Respiratory rate is 50 per minute. Chest movement appears shallow. Bilateral crepitations present. FiO2 requirement has been increased. Support of 12/8. Pulse oximetry shows 89 to 90% since 4 hours. Falling rapidly. SpO2 falls very rapidly when he take out the mask to take some sort of water. And he not able to take anything, not able to eat since 1 day. It means child is so low he is not able to even drink water, not able to eat, lethargic, sleepy, and very important is heart rate. There is tachycardia, there is tachypnea. Means that this child is not fit for NIV, non-invasive ventilation. This child is only on the clinical ground. We can say this child is fit for ventilation, and I will like to refer the child to Kavita ma'am for intubation, and I would like to intubate the baby and will start the ventilation. So what will be the ventilatory setting? Child is already intubated with pre-medication has been given. Child is on Bain circuit or Ambubag, and we have to set the ventilator. So in ventilator, 6 things are there: mode, setting the rate, setting the tidal volume or pressure, IE ratio, FiO2 and PEEP. So I will not go to the mode, details of the mode, as Thapar sir already has told what is the different ventilatory mode. Which mode is the best? Friends, lots of modes are coming up. If you go and see the ventilator, and any company is coming with the ventilator, they are saying कि I have 16 mode, I have 18 mode. कोई भी 10 से कम बोलता ही नहीं है, लेकिन अपने हाथ में है SIMB mode. Basically CMB mode है, ACMB mode है, SIMB mode है, and everybody is well familiar with the SIMB mode. तो आई वुड लाइक टू चूज SIMB मोड. अगर आप अपने किसी मोड के लिए कंफर्टेबल हैं तो आप अपने मोड से वेंटिलेट कर सकते हैं, बट डोंट यूज CMB मोड, बिकॉज अगर स्पॉन्टेनियस है तो चाइल्ड respiration will fight against the ventilatory respiration, child will develop pneumothorax. तो आई वुड लाइक टू प्रीफर SIMB मोड. अब बात आती है SIMB मोड में हम इसको प्रेशर लिमिटेड रखें कि वॉल्यूम लिमिटेड रखें. प्रेशर लिमिटेड फ्रेंड्स हम रखते हैं न्यू बॉर्न बेबी में बिलो 1 month, एंड वॉल्यूम लिमिटेड हम रखते हैं पीडियाट्रिक पेशेंट में 6 to 8 ml पर kg. बट पीडियाट्रिक पेशेंट में हम प्रेशर लिमिटेड मोड भी रख सकते हैं. लिमिटेड का मतलब है कि सपोज अगर हमने PIP प्रेशर PIP हमने सेट किया 16, तो जब सर्किट का प्रेशर 16 होगा वेंटिलेटर वॉल्यूम देना बंद कर देगी. वॉल्यूम लिमिटेड मींस कि व्हेन द वॉल्यूम सेलेक्टेड set volume is achieved, ventilator will stop giving the breath. तो वॉल्यूम कितने ml सेट करते हैं? 6 to 8 ml पर kg. तो हमारा बच्चा जो देव है वो 30 किलो का है, तो हम 180-200 ml वॉल्यूम सेट करेंगे. जो बेबी के लंग्स को 160-180 ml वॉल्यूम डिलीवर हो जाएगा, वेंटिलेटर विल स्टॉप गिविंग द वॉल्यूम. तो हम मोड वही यूज करेंगे जिसके लिए हम फेमिलियर हैं. बोथ आर इफेक्टिव. इंपॉर्टेंट पार्ट है कि इन कोविड, बिकॉज हमारा बच्चा जो है 12/8 80 FiO2 पे मेंटेन नहीं कर रहा है, जबकि इसका सैचुरेशन 100% होना चाहिए. अगर PO2 आप कराते हैं तो 300 होना चाहिए, जो कि नहीं है, बहुत कम है. तो इंपॉर्टेंट पार्ट है कि अगर हमने वॉल्यूम मोड दिया है बच्चे को, वॉल्यूम मोड से हम वेंटिलेट कर रहे हैं, मीन्स कि 180 ml हमने दिया, तो मॉनिटर द पीक प्रेशर विच इज वेरी इंपॉर्टेंट. ऐसा तो नहीं कि लंग्स हमारे इतने खराब हैं कि उतने वॉल्यूम को डिलीवर करने के लिए बहुत हाई प्रेशर लगाना पड़े, क्योंकि लंग्स हमारे कंप्लायंट ही नहीं है. तो प्रेशर जो पीक प्रेशर है This should not go beyond 32, otherwise there will be damage to the lung. Second part is if pressure mode is used. मान लीजिए हमने PIP 20 पे सेट किया, SIMB with pressure limited, तो हमने प्रेशर 20 पे सेट किया, तो जब भी सर्किट पे प्रेशर 20 होगा तो वेंटिलेटर विल स्टॉप गिविंग द ब्रेथ. तो वॉल्यूम इज एडिक्वेट और नॉट, मीन्स की एटलीस्ट 6 ml पर केजी वॉल्यूम जाना चाहिए. तो 30 किलो का बच्चा है तो हम अगर PIP हमने 20 रखा है तो वॉल्यूम हमारा 180 ml के आसपास होना चाहिए. अगर कम है इसका मतलब कि लंग्स काफी खराब है, हमें प्रेशर थोड़ा सा बढ़ाना पड़ेगा. So this was about ventilatory mode. Now coming to the rate. Rate basically depends on the physiological respiratory rate. जैसे न्यूबॉर्न बेबी का रेस्पिरेटरी रेट 40 to 60 होता है. तो अगर हम मानते हैं 40 रेस्पिरेटरी रेट है, 1 मिनट में 40 बार सांस ले रहा है, तो उसकी एक साइकिल 1.5 60/40 1.5 सेकंड की हुई. ठीक है, तो 1.5 सेकंड की उसकी एक साइकिल हुई. तो इस तरीके से हम डिसाइड करते हैं कि अगर न्यूबॉर्न बेबी है तो उसका फिजियोलॉजिकल 40 to 60 है तो 40-50 हम रेट रखेंगे. 1 month to 1 year है तो हम 30-35 तक रख लेंगे. 1 year to 5 है तो हम 20-25 के आसपास रखेंगे. एडोलेसेंट या बड़ा बच्चा है तो हम 15-16-12 के तक रख सकते हैं. इंपॉर्टेंट ये है रेस्पिरेटरी रेट जितना ज्यादा हम बढ़ाएंगे CO2 वास आउट होता है, तो हम टाइट्रेट कर सकते हैं EtCO2 से या PCO2 से हम इसको टाइट्रेट कर सकते हैं. Now coming to the tidal volume or inspiratory pressure. This is very important. ऑलरेडी हम लोगों ने डिस्कस कर लिया है कि वॉल्यूम इज 6 to 8 ml पर केजी. तो हमारा बच्चा 30 किलो का है तो इट शुड बी 180 ml. अगर हमने PIP प्रेशर पीक इंस्पिरेटरी प्रेशर इफ इन प्रेशर लिमिटेड हम प्रेशर सेट करेंगे 22 सेंटीमीटर ऑफ वाटर. इतना हाई क्यों हमने सेट किया? इतना हाई हमने इसलिए सेट किया क्योंकि बच्चा 12/8 प्रेशर पे 80 FiO2 पे भी सही से मेंटेन नहीं कर रहा. 88-89 आ रहा था और हटाते ही एकदम से डिप कर जा रहा था. तो हम थोड़ा हाइयर लेके चलेंगे, जरूरत पड़ने पे धीरे धीरे कम कर लग सकते हैं, वीन कर सकते हैं. एंड इम्पॉर्टेंट पार्ट है कि व्हाट डू वी वांट टू अचीव. हम क्या अचीव करना चाहते हैं? हम अचीव करना चाहते हैं कि अगर हमने वॉल्यूम लिमिटेड रखा तो प्रेशर शुड नॉट गो बियॉन्ड 32, और अगर हमने प्रेशर लिमिटेड रखा तो वॉल्यूम शुड बी अराउंड 180 ml 160 to 200 ml. अगर बहुत ज्यादा कम आ रहा है, 150 से कम आ रहा है, इट मीन्स कि दैट प्रेशर इज नॉट सफिशिएंट, वी हैव टू इंक्रीज द प्रेशर. तो वी हैव डिस्कस्ड वेंटिलेटरी मोड एंड रेस्पिरेटरी रेट, टाइडल वॉल्यूम और PIP पीक इंस्पिरेटरी प्रेशर. नाउ कमिंग टू द IE रेशियो. IE रेशियो कितना होना चाहिए? बहुत इंपॉर्टेंट है. IE रेशियो शुड बी 1:2 to 3. 1:2 to 3 मीन्स I और E में 1:2.5 3 तक हम ले सकते हैं. इंपॉर्टेंट पार्ट है, अगर न्यू बॉर्न बेबी है, इन न्यू बॉर्न बेबी रेस्पिरेटरी रेट इज 40 to 60, तो इन 1 minute इज 60 सेकेंड. तो 60 सेकेंड में 40 रेस्पिरेशन हमें देना है, तो एक रेस्पिरेशन का टाइम 1.5 सेकेंड हुआ. तो यहाँ पे हम IE रेशियो 1:2 करने के लिए हम I रखेंगे 0.5, तो E हो जाएगा 1 सेकेंड, तो 1:2 हमारा अचीव हो जाएगा. तो इन नियोनेट I इज always lesser compared to the older child or adult patient because physiological respiratory rate is higher. In bigger baby or adolescent or in adult more than 12-year baby, physiological respiratory rate is around 15. तो एक साइकिल हमारी 15 चौके 60 4 सेकंड की होती है. तो I अगर हम 1 सेकंड रखते हैं तो E हमारा 3 सेकंड हो जाएगा. तो जितना बड़ा बच्चा होगा, जितना ज्यादा वेट वाला होगा, हमें I को उसी हिसाब से ज्यादा रखना होगा. दैट इज 1.2 0.8 इस तरीके से हम सेट करते हैं, सो दैट कि 1 IE रेशियो शुड बी 1:2 to 3. So we have discussed ventilatory mode, SIMB mode, and pressure limited or volume limited. We have set the respiratory rate according to the physiological parameter. We set the volume, we set the pressure, we have set the IE ratio. Next is FiO2. Friends, FiO2 should be set as per your choice. Why I am saying? Because in this child, particularly in this child was not maintaining saturation on BiPAP 80% FiO2, 12/8 प्रेशर, तो हम 40 देंगे तो एकदम से डीसेचुरेट करेगा, हाइपोक्सिया में जाएगा. तो वी विल स्टार्ट विद द हायर 75, 80 और समटाइम 100. तो इट डिपेंड्स ऑन द क्लिनिकल कंडीशन ऑफ द पेशेंट. तो FiO2 is always decided by the clinical condition, and it should be kept higher and gradually decrease the FiO2 as per the SpO2 or PO2. So we have discussed the FiO2. Last parameter is the PEEP. What is PEEP? PEEP is very, very, very important, and with the advent of nasal CPAP in newborn baby, importance of PEEP has increased because it elevates the use of surfactant in newborn baby. So what is PEEP? Basically PEEP. PEEP is positive end expiratory pressure. हम इसको चाहे नाक से दे, चाहे हम इंडोट्रैकियल ट्यूब से दे, चाहे इनवेजिव वेंटिलेशन में. पीप क्या करता है? पीप स्ट्रेचेस द एयरवे. ये ओपन अप कर देता है जो भी सैगिनेस होती है. जैसे एडल्ट पेशेंट में जिनको स्नोरिंग की प्रॉब्लम होती है, वो एक पीप डिवाइस लगा के नाक पे सोते हैं ताकि पूरा एयरवे डिस्टेंडेड हो एंड स्नोरिंग वाली प्रॉब्लम ना हो. जो एप्निया होता है वो भी सही हो जाता है. तो पीप इज वेरी इंपॉर्टेंट बिकॉज इट ओपन अप द एयरवे, इट स्प्लिंट्स द एयरवे फ्रॉम इनसाइड. Second very important part is PEEP, what it does. During COVID pneumonia or in any pneumonia, alveoli are getting collapsed because loss of surfactant. So what does PEEP is positive end expiration. At the end of expiration, it gives a positive pressure in the alveoli to prevent collapse. तो बेसिकली इट्स यू कैन से कि ये कोलैप्सिंग प्रेशर के आसपास हमें पीप को रखना चाहिए. एंड इन कोविड निमोनिया वी शुड स्टार्ट विद 7 to 8 सेंटीमीटर ऑफ वाटर. जरूरत पड़ने पे हम बढ़ा सकते हैं, बट इन पीडियाट्रिक पेशेंट वी डोंट गो बियॉन्ड 12. बट आई डिड ड्यूटी इन द कोविड ICU, adult ICU, and intensivist here at my place used to increase the PEEP to 14, but in pediatric patient 12 is okay. So I have already told it recruits. What do you mean by recruits? तो millions alveoli है, पता चला कि 10% alveoli हमारे collapsed हैं due to COVID ARDS and COVID pneumonia. तो what is जो collapsed alveoli है, this PEEP positive pressure will open up the collapsed alveoli, so volume of ventilation, area of exchange will increase. So we can decrease the FiO2 because it helps in oxygen transfer from alveoli to because of increase in the area. Second, ये lungs को better, ये अभी next PPT में आपको बताएंगे how it keep the lung in the better part of the compliance, because all the time it open up the alveoli and PEEP is kept from where alveoli are getting collapsed. तो जैसे एक बैलून का अगर हम एग्जांपल लें कि बैलून अगर कोलैप्स्ड है तो क्या होता है, जब हम बैलून कोलैप्स्ड होता है तो हम बैलून को शुरू में जब फुलाते हैं तो बहुत ज्यादा प्रेशर लगता है, वी हैव टू इंक्रीज मोर प्रेशर, बट आफ्टर सम टाइम प्रेशर रिक्वायरमेंट इज इंक्रीज्ड एंड वॉल्यूम जनरेशन इज मोर. कम प्रेशर पे हम ज्यादा वॉल्यूम इन्फ्लेट कर सकते हैं लंग्स में. तो पीप हमारा जो शुरू का पार्ट है उतने पे हमारे बैलून को बना के रखता है. बैलून मीन्स हमारे दोनों लंग्स को माइल्डली इन्फ्लेटेड रखता है ताकि कम प्रेशर पे भी ज्यादा से ज्यादा वॉल्यूम हम डिलीवर कर सके. दिस इज नोन एज बेटर पार्ट ऑफ द कंप्लायंट. ये पीप का काम है. इट प्रिवेंट्स एटिलेक्टोट्रामा. अगर हम पीप नहीं लगाएंगे तो व्हाट हैपेंस, एल्वेलाई विल बी गेटिंग कोलैप्स्ड ऑल द टाइम एंड ऑल द टाइम वी हैव टू इन्फ्लेट द एल्वेलाई एंड वेंटिलेटर हैज टू वर्क मोर and even spontaneous is there, so patient has to work more to. So basically PEEP will prevent atelectotrauma. But very important, I was saying ki PEEP should not be go beyond 12 in pediatric patient. 13 14 पे आपको invasive monitoring करनी पड़ेगी, but 12 पे हम रख सकते हैं. बिकॉज पीप बढ़ाने पे क्या होता है कि सुपीरियर वेना कैवा, इंफीरियर वेना कैवा सब पे प्रेशर पड़ता है एंड वीनस रिटर्न कम हो जाता है. जब वीनस रिटर्न कम होगा तो स्ट्रोक वॉल्यूम कम होगा, स्ट्रोक वॉल्यूम कम होगा तो बीपी हमारा फॉल कर जाएगा. तो हाइपरटेंशन इज द बिग चैलेंज अगर हम पीप ज्यादा बढ़ाते हैं. दूसरा, ज्यादा प्रेशर से बैरो ट्रॉमा हो जाएगा. नेक्स्ट इज ट्रिगर सेंसिटिविटी। बेसिकली वेंटिलेटर में ट्रिगर ऑलरेडी सेट होके आते हैं। अगर आप बहुत ही वेल वर्स्ड है वेंटिलेटर चलाने से तो इसको टच करिए, अदरवाइज डोंट टच द ट्रिगर बिकॉज इट विल क्रिएट द प्रॉब्लम। बेसिकली ट्रिगर्स आर टू टाइप, फ्लो ट्रिगर एंड प्रेशर ट्रिगर। फ्लो ट्रिगर, प्रेशर ट्रिगर दोनों एक ही है। प्रेशर ट्रिगर मीन्स कि जब भी सर्किट में प्रेशर निगेटिव होगा वेंटिलेटर इसको सेंस करेगा और एक ब्रेथ दे देगा। जैसे एसीएमबी मोड में ऑल द ब्रेथ को पेशेंट, जब भी पेशेंट नेगेटिव प्रेशर बनाएगा तुरंत वेंटिलेटर सपोर्ट कर देगा। फ्लो ट्रिगर, जब भी फ्लो मतलब सर्किट में जब भी फ्लो टुवर्ड्स पेशेंट होगा वेंटिलेटर विल सेंस दैट फ्लो एंड वेंटिलेटर विल गिव द ब्रेथ। तो फ्लो ट्रिगर इज सेट अराउंड 2 to 4, that is appropriate. Don't touch much more the trigger, but trigger is important। जैसे अगर हमने 3 का सेट किया ट्रिगर, फ्लो ट्रिगर 3, लेकिन पेशेंट को हमने वेंटिलेटर रेस्पिरेटरी रेट सेट किया 15 और दिखा रहा है 40, मीन्स की 26 ब्रेथ पेशेंट अपना ले रहा है। इससे वर्क ऑफ ब्रीदिंग बढ़ेगी, फैटिग बढ़ेगा, लैक्टिक एसिडोसिस हो सकती है। तो हम इसको कैसे रोकेंगे? हम ट्रिगर को बढ़ा दें, 3 को हमने 4-5 कर दिया तो पेशेंट की वो ब्रेथ जो कि कम पावर की है उसको वेंटिलेटर रोक देगा। वो ब्रेथ जिनमें प्रेशर 4-5 तक जा रहा है वही को वेंटिलेटर सपोर्ट करेगा। तो ट्रिगर इज इंपॉर्टेंट टू प्रिवेंट हाइपर वेंटिलेशन, बट अभी भी मैं यही एडवाइस करूंगा इसको ज्यादा टच न करें। राइज टाइम इज 5 to 10%, मीन्स की इंस्पिरेशन के कितने परसेंट टाइम में हम पूरा वॉल्यूम डिलीवर कर दें, ये भी वेंटिलेटर में फिक्स होता है। यू डोंट हैव टू चेंज द राइज टाइम। तो हमने सारे पैरामीटर पढ़ लिए। हमने पेशेंट्स को प्रेशर कंट्रोल मोड पे डाला है। पीआईपी हमने 22 रखा, पीप इज 8, आई रेशियो इज 1:8, रेस्पिरेटरी रेट इज 18 पर मिनट, FiO2 हमने 80% पे स्टार्ट किया, ट्रिगर अभी हमने 0 रखा है। सिडेशन बहुत इंपॉर्टेंट है क्योंकि बच्चे एंडोट्रैकियल ट्यूब नोच देते हैं। व्हाट डू वी मॉनिटर? हम क्या मॉनिटर करेंगे? मॉनिटर हम वही करेंगे जिसके कारण हमने पेशेंट को वेंटिलेट किया है। हमने पेशेंट को वेंटिलेट क्यों किया है? क्योंकि पेशेंट को हाइपॉक्सिया था, क्योंकि पेशेंट को टैकीकार्डिया था, पेशेंट को टैकेपनिया था, पेशेंट स्लीपी था, पेशेंट लेथार्जी था। तो हम पेशेंट के सारे वाइटल्स देखेंगे, पेशेंट्स का हार्ट रेट देखेंगे, रेस्पिरेटरी रेट देखेंगे, बीपी देखेंगे, EtCO2 अवेलेबल है तो हम वो देख ले, बाइलेटरल चेस्ट राइज देख लेंगे और सारे वेंटिलेटरी पैरामीटर। जैसे हमने इसको प्रेशर सेटिंग पे रखा है तो आई वुड लाइक टू सी वॉल्यूम 180 ml डिलीवर हो रहा है कि नहीं हो रहा है। आई वुड लाइक टू सी पीक प्रेशर इन द सर्किट शुड नॉट गो बियॉन्ड 32। And ABG not needed all the time. We do ABG whenever we want to know ki what is the condition of ABG, condition of CO2, condition of the acid, what is the alveolar arterial gradient। अगर पेशेंट डिटोरेट कर रहा है तब हम ABG कराते हैं कि alveolar arterial gradient जानने के लिए। अदरवाइज routinely don't do ABG, it's not a fascinating thing। हाउ टू ऑप्टिमाइज द वेंटिलेशन? हमने इंट्यूबेट किया, वेंटिलेट किया, बट पेशेंट इज नॉट इंप्रूविंग, SpO2 इज नॉट इंप्रूविंग, टैकीकार्डिया इज नॉट इंप्रूविंग। तो व्हाट कुड बी द प्रॉब्लम? सेटिंग्स आर नॉट राइट। हो सकता है 22 पे नहीं मेंटेन कर रहा हो, वॉल्यूम नहीं डिलीवर हो रहा है तो हमें प्रेशर बढ़ाना पड़ेगा। पेशेंट इज अंडर सीडेटेड तो फाइट करता है बार बार, और सम टाइम वो गुडल एयरवे को निकाल के ET को च्यू कर लेता है। फीवर हो तो मेटाबॉलिज्म बढ़ जाता है तो वाइटल नहीं इंप्रूव करेगा। सिक्रीशन है वेंटिलेटरी सर्किट में या एंडोट्रैकियल ट्यूब में। चेस्ट राइज हम लुक कर देखेंगे कि भाई चेस्ट राइज कैसा है, एक्सेसिव किंकिंग या लीकिंग तो नहीं है। तो चेस्ट राइज अगर बहुत ज्यादा है तो हम PIP को कम करेंगे, चेस्ट राइज कम है तो बढ़ाना चाहिए, और हम इसको टाइडल वॉल्यूम से हम इसको मॉनिटर कर सकते हैं। हाउ टू ऑप्टिमाइज द वेंटिलेशन? Friends, you can see my cursor ki this is the A square, this is B square, this is C square. A square is basically, you can see on X axis pressure is there, on Y axis volume is there. You can see from here to here we are increasing the pressure, but volume increment is hardly 1 ml, 2 ml. But from here to here, from here to here, you can see pressure increment is same, but volume increment is very high. This is the compliant part of the lung and this is the beauty of PEEP. यहाँ पे अगर हम पीप रखते हैं तो यहाँ पे हमारा एक्सप्रेशन खत्म हो जाएगा इस प्रेशर पे, और हम यहीं से इंस्पायर कराएंगे तो कम प्रेशर पे अच्छा वॉल्यूम डिलीवर हो पाएगा. तो दैट इज द पीप. सेकंड इज यू कैन सी द स्क्वायर सी. From here to here, we are increasing the pressure from here to here, and this is known as the beaking effect. And you can say volume increment is very less. तो अगर PIP मान लीजिए हमारा वॉल्यूम जो है आया 140 ml, हमारे सर ने कहा कि इंक्रीज द PIP कि 25 तक आ गए और ठीक है कोई बात नहीं, आप इसको 26-27 कर दो. अगर PIP बढ़ाने से वॉल्यूम इंक्रीमेंट नहीं हो रहा है तो हम पुरानी सेटिंग पे आ जाए, वॉल्यूम नहीं बढ़ रहा है, बीकिंग स्टेप स्टार्ट हो गया है, दिस इज PIP. इसके बियॉन्ड बढ़ाने से केवल लंग्स को इंजरी होगी, वॉल्यूम नहीं बढ़ेगा. तो वेरी इंपॉर्टेंट पार्ट इज सेट द PIP एंड PEEP, सीइंग द लूप ऑफ प्रेशर वॉल्यूम लूप, एंड दिस इज नोन एज लोअर इंसफलेशन पॉइंट एंड दिस इज नोन एज अपर इंसफलेशन पॉइंट. यहीं पे हमें PIP को सेट करना है. कुछ वेंटिलेटर जो BPL UPL के हैं उसमें पूरा बता देता है कि व्हाट इज द लेवल ऑफ LIP, व्हाट इज द लेवल ऑफ UIP, and you can set directly. They are very advanced ventilator, but they are very costly. How to optimize the ventilation? तो टाइडल वॉल्यूम लो हो, टाइडल वॉल्यूम एंड रेस्पिरेटरी रेट को मल्टीप्लाई कर दे तो मिनट वॉल्यूम अगर लो आता है, इट मीन्स कि वॉल्यूम पेशेंट्स के अंदर नहीं जा रहा है. इट मीन्स कि या तो लंग्स बहुत ही ज्यादा खराब है, डिलीवर नहीं हो रहा है, तो हम PIP को बढ़ाएंगे. हम देखेंगे कहीं पे लीक तो नहीं है, ट्यूब्स को पूरा चेक करेंगे. ठीक है, तो ये एक तरीका हो. दूसरा है सडन राइज इन पीक प्रेशर. कई बार क्या होता है, पेशेंट ब्रोंकोस्पाज्म में चला जाए, सिक्रीशन आ जाए, कोई स्पुटम बलगम आके ईटी में फंस जाए, या गुडल्स एयरवे निकला हुआ है, पेशेंट उसको च्यू कर दे. एट दैट टाइम हम सक्शन करके पूरा एयरवे को क्लियर करेंगे और हम उसको नेबुलाइज कर सकते हैं फॉर ब्रोंकोस्पाज्म. टारगेट ब्लड गैस इज ऑलवेज, डोंट ट्राई टू टारगेट बिल्कुल नॉर्मल ABG. 7.3 to 7.5 is acceptable. PaO2 55 to 80, PaCO2 45 to 55. Some hypercarbia is allowed. Lactates should be less than 4. Electrolytes should be normal. How to optimize the blood gas? Suppose इस सेटिंग के बाद भी PO2 कम आ रहा है, तो PO2 बढ़ाने का क्या क्या तरीका है? पहला है हम PEEP बढ़ाते हैं. PEEP बढ़ा दे ताकि कम प्रेशर पे अच्छा वॉल्यूम डिलीवर हो और एरिया ऑफ वेंटिलेशन बढ़ जाए, तो PEEP बढ़ा दें. दूसरा I बढ़ा दें. I अगर हम बढ़ाएंगे तो हमारा ऑक्सीजनेशन बढ़ेगा, बट I हम ज्यादा बढ़ा दिए, IE रेशियो 1:1 कर दिए, तो इसका नुकसान ये होगा कि CO2 रिटेंशन हो सकता है. तो वी हैव टू मॉनिटर द CO2. तो PEEP बढ़ाएंगे, I बढ़ाएंगे, FiO2 बढ़ा सकते हैं. थर्ड इज प्रोनी. 16 आवर 14 to 16 आवर के लिए हम बेबी को प्रोन कर दे तो कुछ एल्वियोलाई जो कि कोलैप्स्ड हैं वो रिक्रूट हो जाती हैं, वेंटिलेशन इंप्रूव करता है. अभी तक फ्रेंड्स हम लोगों ने पीडियाट्रिक में नहीं ट्राई किया है, एडल्ट में ट्राई किया है 2-3 पेशेंट में, और नियोनेट में हमने ट्राई किया है. प्रोनिक इज वेरी गुड, नियोनेट में बड़ा अच्छा काम करता है. तो ऑक्सीजन बढ़ाने के लिए हम PIP, I रेशियो, I एंड FiO2 एंड प्रोनिक 4 पैरामीटर है जिससे हम PO2 बढ़ा सकते हैं. हाई PaCO2, PaCO2 अगर ज्यादा है तो हम इसको वॉश आउट करना है. वॉश आउट करने का तरीका है रेस्पिरेटरी रेट बढ़ा दे, जैसे रेज्ड आइसिटम हम करते हैं कि रेस्पिरेटरी रेट बढ़ा दो, CO2 वॉश आउट हो जाता है. ट्रीट ब्रोंकोस्पाज्म अगर है, कोई सिक्रीशन है, ट्यूब ब्लॉक है, ये हम सारा हटा दें. और जैसे I बढ़ाने से ऑक्सीजन बढ़ता था, वैसे E बढ़ाने से हमारा CO2 वॉश आउट हो जाएगा. वेंटिलेटरी अलार्म. अब यही बच्चा है हमारा 30 kg का है और वेंटिलेटरी अलार्म अगर एडल्ट के हिसाब से सेट है तो बहुत ज्यादा गड़बड़ हो जाएगा, हमें पता ही नहीं चलेगा. तो हम टारगेट किए थे मिनट, हमारा टाइडल वॉल्यूम 180 ml, तो हम इसको सेट करेंगे 30-40 ml ऊपर, तो हम इसको 250-260 ml अपर लिमिट और लोअर लिमिट हमने 130-40 सेट कर दी. जब भी इससे कम आएगा तुरंत वेंटिलेटर विल गिव अलार्म. तो अलार्म हर बेबी के वेट के हिसाब से हमें सेट करना चाहिए, न कि प्री सेट पे रख देना चाहिए. अदरवाइज योर वेंटिलेटर विल ऑलवेज अलार्म लाइक एनीथिंग. राइट, Important part is कि never ask your sister or ward boy or sweeper to switch off the alarm, otherwise patient will deteriorate and you will not able to know. तो टाइडल वॉल्यूम पीक इंस्पिरेटरी हमने पीआईपी मान लीजिए 22 पे सेट किया, सर्किट का प्रेशर हम 32-33, हम 32 ऊपर नहीं चाहते हैं जाए तो हमने 35 पे सेट कर दिया, लोअर प्रेशर हमने 12 पे सेट कर दिया। मान लीजिए ट्यूब कहीं लीक कर गई, कहीं कट गई या कहीं पे डिसलॉज हो गई ट्यूब, तो एकदम से पीआईपी कम होगा, वेंटिलेटर विल गिव अलार्म। लेकिन अगर हमने बहुत कम सेट किया तो अलार्म नहीं देगी। ऐसे ही FiO2 है, ऐसे ही हमारा पीप है। तो हमने क्या सीखा कि हाउ टू स्टार्ट द इनवेटिव वेंटिलेशन इन हाइपोक्सेमिक चाइल्ड, how to monitor the child. Very important part is vitals, general condition is far important, much more important than any investigational parameter. How to optimize the oxygenation and ventilation considering all the monitored parameter. Thank you. Thank you so much.
Thank you, Dr. Yashwant. The presentation was excellent as always. And there are some questions for you. So there is one question. Please repeat the IE ratio.
Okay. IE रेशियो, I होता है बेसिकली इंस्पिरेटरी टाइम। हमने जैसे वेंटिलेटर होता है एक, वो इंस्पायर कराता है, और E होता है जब हमारा एक्सपिरेशन होता है। तो IE रेशियो बेसिकली 1:2:3 रखते हैं। इससे हमारा नॉर्मल ऑक्सीजनेशन एंड नॉर्मल CO2 बना रहता है। कैसे सेट करते हैं, डिपेंड्स अपॉन द फिजियोलॉजिकल रेस्पिरेटरी रेट। जैसे नियोनेट है, नियोनेट का रेस्पिरेटरी रेट इज 40 to 60, तो हम 40 सेट कर दिया अपने वेंटिलेटर में कि 40 पे हम रेस्पिरेशन देंगे। बड़ों में क्या करते हैं वो लोग I1 सेट करते हैं। तो अगर आप देखो 60 सेकंड में 40 ब्रेथ देनी है, मतलब एक ब्रेथ के लिए 1.5 सेकंड हमारे पास बचा। अगर हमने I1 सेट कर दिया तो E के लिए 0.5, ये इनवर्स रेशियो वेंटिलेशन हो जाएगा एंड देयर विल बी रिटेंशन ऑफ द CO2, पेशेंट विल बिकम मोर स्लीपी and all the parameter will be disturbed. So I is set according to the respiratory rate, set respiratory rate. तो अगर रेस्पिरेटरी रेट हमारा ज्यादा है तो हमें I को कम रखना चाहिए, 0.4, 0.5, 0.6 रख सकते हैं, तो E अपने आप हमारा सेट हो जाता है। तो अगर हाइयर रेस्पिरेटरी रेट है तो I हमें कम रखना होता है, और रेस्पिरेटरी रेट अगर लोअर है, जैसे एडोलेसेंट और पीडियाट्रिक पेशेंट और एडल्ट और ओल्डर चाइल्ड, उसमें हमारा रेस्पिरेटरी रेट 20-25 होता है, तो 3 सेकंड की साइकिल होगी, तो वहां पे हम I1 रख सकते हैं, 0.8 रख सकते हैं, और E अपने आप हमारा 2 और 3 के आसपास आ जाएगा। तो होप यू अंडरस्टैंड कि व्हाट इज IE रेशियो।
There is one more question. Is the target tidal volume for ARDS is same as non-ARDS baby in neonate?
Yes. टाइडल वॉल्यूम इज 6 to 8 ml per kg। ये नियोनेट से लेके एडोलेसेंट, एडल्ट एंड ओल्डर पीपल सबके लिए है 6 to 8 ml per kg। दिस इज सेम। अब टाइडल वॉल्यूम को बहुत ज्यादा हम 6 से स्टार्ट करते हैं। अब मान लीजिए टाइडल वॉल्यूम हमने सेट किया इस बच्चे में 180 ml। 180 ml पे हमारा पीआईपी, हम प्रेशर, हम अगर हमने वॉल्यूम पे लिया तो हम प्रेशर मॉनिटर करेंगे। सर्किट का प्रेशर 23, 24, 25 तक आ रहा है, लेकिन पेशेंट अभी भी हाइपोक्सिमिक है, अभी भी रेस्पिरेटरी रेट बढ़ा हुआ है, तो हम इसके टाइडल वॉल्यूम को 7 ml per kg कर सकते हैं, लेकिन 8 ml per kg से ज्यादा नहीं जाते हैं, अदरवाइज वॉल्यूम ट्रॉमा स्टार्ट हो जाएगा। तो 6 to 8 ml इज फिक्स। लोअर से स्टार्ट करेंगे और हाइयर हम जा सकते हैं।
So, is there any difference in tidal volume in a neonate with ARDS or without ARDS?
No. 6 ml per kg। केवल सर्किट का डिफरेंस होता है। बड़ों में, बड़े बच्चों में, एडोलेसेंट में थोड़ी चौड़ी सर्किट होती है। नियोनेट में चूंकि अगर ARDS नियोनेट में जो HMD वाले बच्चे होते हैं उनका वेट जो है 1 kg 1.5 kg, तो वॉल्यूम 10 ml डिलीवर करना होता है, तो पतली सर्किट होती है, अदरवाइज ऑल द वॉल्यूम विल बी लॉस्ट इन द सर्किट। तो बेसिकली नियोनेट में भी 6 ml per kg से हम स्टार्ट करते हैं।
Okay, thank you. Thank you, Dr. Yashwant, for this excellent presentation.
Thank you, ma'am.
So the Dr. Yashwant has ventilated the baby so well that the child has improved now and the child is fit for weaning and extubation. So Dr. Anubha Srivastav is going to tell us how to wean the child from mechanical ventilation and how to extubate. Dr. Anubha is Associate Professor at Avalon Medical College, Prayagraj. So welcome, Dr. Anubha.
Good afternoon, ma'am. Thank you, ma'am. So I'll start sharing my screen. So after the whole day of ventilation, now it's time to wean the child, bring down his ventilatory support, and finally extubate the child. So this is the topic I'll be taking today. So these are the key points that I'll be discussing. So mechanical ventilation is key step in management of critically ill child. This we have all agreed that, especially in critically ill patient that we are expecting in the corona pandemic. So mechanical ventilation is an important part of it, and it can be life-saving. But as important as is ventilation, so is its discontinuation as proper time. So we'll be discussing the goals of weaning from mechanical ventilation. What is the physiology behind it? How to test for readiness of weaning and extubation, and we'll learn the actual process. So the two terms that I've been discussing will be weaning and extubation. So weaning is the transition from the ventilatory support to completely spontaneous breathing while gradually withdrawing positive pressure support. So we have been mechanically ventilating the child, and now we want the child to be off his ventilatory support. So that whole process of gradually decreasing the ventilatory support is called weaning. And extubation is, as the name suggests, the process of actual removal of the endotracheal tube. So if you see the journey of mechanical ventilation, the duration of actual mechanical ventilation and the duration of weaning is mostly they are more or less equal. In fact, weaning phase accounts for approximately 40% of the total duration of mechanical ventilation. So this emphasizes how important is the process of weaning. So we have to decide what the respiratory load the patient can sustain and what is the respiratory capacity, and decide the balance between these two factors, and hence we have to judge whether the patient is fit for weaning or decreasing support or not. So respiratory load are the low compliance due to the disease process or the high resistance, the increased dead space. All these lung physiology can be due to the pathology that the child is facing. Apart from the respiratory parameters, there are cardiovascular and chest wall diseases also. So these can also hamper its ability to handle the respiratory load. So what will fight against this respiratory load is its neural drive, the diaphragmatic function, the peripheral nerves, the functioning of its nerve. So not only its respiratory capacity, but also its other major organs functioning, and also the neuromuscular coordination. So we have to recognize when this balance has been reached, when the load has the child is in a position to overcome the load, and we have to decide that now the child may not be needing such high support, and we can come down on the support. So the weaning has three phases. First, there is phase of actual mechanical ventilation or the pre-weaning, and then you do the weaning process. Then before actual ventilation, we give some small trials of spontaneous breathing that I'll be discussing later in my talk. So when to wean? The important question is, when do we start weaning? So first we have to see, as we have discussed, that the whole ventilation has two important components: oxygenation and ventilation. While oxygenation deals with the level of oxygen in blood, ventilation, the adequate ventilation determines that the CO2 has been washed out from our system, and the parameters are maintained appropriately. So seeing these parameters, these should be in normal ranges. Apart from that, there should be absence of major organ system failure, and at local level, the airway protective mechanism should be intact. So putting it quantitatively, the PaO2 should be above 60 millimeter of mercury, at FiO2 as low as 40%. PEEP should be less than equal to 5 centimeter of water. The respiratory rate, minute ventilation, CO2, all these ranges, all these values should be normal ranges. The ventilatory drive should be intact. Otherwise, once if the child doesn't have a good ventilatory drive, good neuromuscular power, then once you bring down the ventilatory support, the child may not be able to sustain on lower supports and may again require higher setting. So we have to see that respiratory muscles are functioning properly. All major organs, CVS, electrolyte, nutrition, liver, GIT, they are functioning well. And another very important component in pediatric handling is temperature. So the child should be in maintaining normothermia also, because a hypothermic or a hyperthermic child can have deleterious effects on his other major organs due to non-maintenance of temperature. And the local airway, the airway protective mechanism should be appropriate. There should be appropriate level of consciousness. There should be intact cuff reflex and gag reflex. So when we come to actual weaning, it can be either a slow weaning or a rapid weaning. So in slow weaning is usually given for conditions which have a prolonged pathology, like multi-organ system failure or pump failure. And if the child has been on prolonged ventilation for more than 3 days, then we can go for slow or gradual weaning. But in cases where pathology is quick and reversible, and the child has been ventilated for less than 72 hours, then we can decide on a rapid weaning. So why these two approaches? Some say that we should be cautious because failed extubation and then again re-intubation after failed extubation can increase mortality and morbidity. But those who favor modern approach, they say that in pediatric, 50% are self-extubate. Patients are self-extubated and they don't require re-intubation. So why not do a rapid weaning or extubation in a controlled environment? So what are the weaning modes? You have been told about the weaning, the ventilatory modes today. So out of these three, SIMV, pressure support, and T-piece ventilation can be used as weaning methods also. So so you decide when the ventilatory support is reduced as patient is increasingly able to resume its own work of breathing, and so you gradually decrease the ventilatory support. So coming to all these modes separately, in SIMV, the patient's respiratory muscles would work during spontaneous breathing, and rest during the muscles and the system, they rest during mandatory breath. So if you recall the waveforms that you have been shown, so here you can see the SIMV waveform. This bigger waves were the one given by the machine, and these smaller waves were patient triggered, and there were his own efforts. So in SIMV, what we do is we see that if the patient is maintaining normal parameters, is not having increased work of breathing with these numbers of mechanical breaths, then gradually we decrease these mechanical breaths, the number of mechanical breaths, and the number of patient breaths increases. And as the patient improves, these mechanical breaths can be decreased, their values can be, their pressure supports can be decreased, and also their frequency can be decreased, and gradually the patient breaths take over. So here in SIMV, we reduce the mandatory rate progressively, but in small steps, usually in steps of 1 to 2 breaths per minute, and see whether the patient's work of breathing is able to maintain the normal parameters. In some ventilators, we have the option of adding pressure support to SIMV settings. So in these, even the breaths taken by the patients are partially supported by the ventilator. In pressure support kind of weaning, the patient controls the rate the timing and depth of each breath. So each breath is patient triggered and patient controlled. So here what we do is gradual reduction of level of support as long as the patient is able to sustain his spontaneous breathing with maintaining normal parameter. And once this pressure comes down, the pressure support is reduced to as low as 5 centimeter of water, and the pressure level is not high enough to contribute significantly to the ventilatory support, then we can think of withdrawing the support. Now this is a T-piece. You can see in this figure, this is a T-piece. So here what we do, one end is attached to ventilator and the ventilatory mode is set to spontaneous or CPAP. So here the advantage is that we get to use the alarms shown by ventilators like the apnea alarm. So here and the ETCO2 alarm. So here it is, the actual mechanism of using T-piece is that it gives small amount of pressure support. So it prevents from the expiratory collapse, and then the T-piece trial is using the ventilator provides a continuous monitoring of patient, and gradually as the patient takes over his breathing, so this pressure support can be reduced. So once you have weaned the patient, now it's time to extubate. So extubation is the process of removal of endotracheal tube. So the primary consideration for extubation is that the initial indication for which the patient was intubated has resolved. If he was put on ventilator due to pneumonia, then pneumonia would have been settled. If it was due to shock, then shock would have been resolved. And we should see if the patient is capable of maintaining a stable airway. So there you can think about extubation. So when to time extubation, again, there can be early extubation or delayed extubation. So in early extubation can lead to failure of extubation and may require reintubation, which increase mortality. And in delay extubation, it increases the duration of hospital stay. Hence, and this again can lead to adverse outcome and increase in mortality. So before we actually extubate the child, it is important to give spontaneous breathing trial. So
There is some technical issue. Dr. Anubhai is joining again, so please wait.